The handouts or review materials must be treated with utmost confidentiality. It shall be the responsibility of the person whose name appears therein that the handouts or review materials are not photocopied or in any way reproduced, shared, or lent to any person or disposed in any manner. Any handouts or review materials found in the possession of another person whose name does not appear therein shall be prima facie evidence of violation of RA 8293. Top-notch review materials are updated every 6 months based on the current trends and feedback. Please buy all recommended review books and other materials.
Good day everyone, I am Dr. Robert Liana Bisamis and welcome to Pathology Pearls Part 2. So before we begin, a few disclaimers and some tips for the upcoming pathology exam. Matagal ang feedback sa amin is napakahirap ng pathology exam. It has a very good reason why it is really hard, and it's because this subject is actually the link between your basic and your clinical subjects. And that makes it hard because it means na anything pwede nila itanong, anything under the sun, pwede nilang itanong sa inyo kasi nga it links up basic concepts in paano nagkakaroon ng disease up to which specific nangyayari per specific disease. Ang maganda na lang dito is you know that there is a limitation, which is the fact that the examiners is going to be using Robbins. Since time immemorial, Robbins naman talaga, ever since Robbins was written, siya ang naging parang textbook ng lahat. So even our consultants is going to be using Robbins as their main reference for your exam. And with that, because your examiner is not a pathologist, your gross and microscopic descriptions will be near verbatim Robbins. So magandang tip siya para aralin. Bakit? Because the skill set, yung skill set ng pathologist na iba sa isang clinician. Okay? Makaya namin i-describe yung mga gross and microscopic descriptions like it's second nature to us, pero not for the general practitioner. Kaya ang mangyayari dyan, kokopyahin nila kung ano man yung description kay Robbins if they are going to use ever those descriptions. Pero warning lang is that most of the time, napapansin namin is they go clinical. So instead of asking those gross and microscopic descriptions, is going to be classic symptoms ng pasyente ninyo instead. Now, with regards to the use of the isang review material known as the Robinson-Cottes Review of Pathology, ito yung Q&A na libro. Pre-pandemic, maganda ang feedback dyan. They really, they have been using the textbook as parang framework when they craft their questions. However, ngayon, dahil nakapag-teachers training tong mga examiners natin, mostly non-samplex na yung questions. But the topics we find tends to repeat. Ang napapansin namin, sometimes when they fixate on a topic, like let's say dermatomyositis, parang mayroong 3 questions sa sunod-sunod na tungkol lang sa dermatomyositis, different facts about that specific disease. And sometimes ang pinaka-complaint na nakakuha namin is that it's not, minsan they can fixate even on the topics na hindi naman tingin namin na pang GP. So mag-ingat lang kayo doon. That's why I'm going to have emphasis on certain topics once we go through the pearls for this pearl session. Now, the use of buzzwords. Now, it really depends on the examiner. Some examiners like to use it. So, parang instead of a description, they use the buzzword parang shortcut na term when referring to a disease. However, sometimes the reverse happens. Instead of using the buzzword, they are going to use the exact description for the buzzword. So for example, ang isa sa mga favorite dyan ay yung Flexner-Winter-Steiner rosette ng retinoblastoma. So ang nangyayari, some exams, they ask outright yung Flexner-Winter-Steiner rosette. Pero may ibang exam, they ask they use the actual description of that finding para para dun sa case nila para medyo malinlang ng konti ang students. So mag-iingat kayo din doon. Now, you may encounter cases and hingings or sequential questions, and that is para we find a test of your testmanship. So, ang nangyayari, may case, tapos sunod-sunod, malas ka if, for example, the answer to number 2 is entirely dependent on the answer in number 1. So, kung nagkamali ka sa number 1, mali ka na agad kay number 2. So, again, mag-ingat kayo sa mga ganong klaseng tanong. I might suggest to break down the case para maintindihan ninyo. Pero minsan talaga, pag hindi mo talaga maintindihan na mental block ka na, doon ka na doon ka na matatalo. Now, next tip, your topics in pathology may also be seen in other exams. So it may cross over. What I mean in here is that sometimes for example, questions in pediatric pathology, isang chapter yun, di ba, kay Robbins? Hindi yan lilitaw kay Robbins, lilitaw yan sa pedia exam ninyo. Or vice versa, instead of asking it's a OB nandun sa patho exam ninyo instead. They may do that. Kaya ang tip ko for the students is that hindi porket tapos na ang patho exam is you will be complacent about it and then go to your next exam tapos tinapon nyo na lahat ng alam nyo sa pathology tapos here comes a patho question. That's kinda it's dangerous. Kasi kayo matatalo kayo sa ganung klaseng situation. And even in some of the other subjects. So that's why you don't throw away whatever you've learned sa basic sciences niyo when you're going to the clinical exams. And at the same time, yung mga natutunan niyo sa clinical subjects niyo, you can always apply that dun sa basic subjects niyo. Okay, so that's why it goes hand in hand, yung pag-aaral nyo in all of the subjects. Okay? So, sometimes madalas dito is OB. So, sometimes madalas na nangyayari is the OB patho questions get asked sa OB instead of sa patho sa patho na exam niyo. So, just be wary about that. And also what we do see is sometimes is topics in the other subjects are seen in the patho exam. Ang feedback na nakuha namin dito, major culprit would be micro and para. So, ano nangyayari? May maraming micro and para questions sa patho. Technically speaking, tama naman kasi we do have a section on infectious diseases in the pathology exam. Pero, yan, is something to be worry about lang na hindi porket tapos na again ang micro and para exam pwede nyo nang kalimutan sa patho exam niyo and vice versa. There's even one anatomy question in the patho exam based on feedback sa isang exam namin. Pero one question lang naman. So, some reminders. This review session will only cover the organ system pathology. Yung part 1 will be covering the basic pathology, yung mga basic concepts in pathology. So this is a Q&A style review, 96 items, and questions were made based on the feedback on previous exams. Do remember that in the feedback what we got, ang nangyayari ay we tend to see na mayroong mga repeating topics. And I'll be mentioning that as we go along dito sa natin, sa pearls natin. My references would always be yung handouts na gawa ni Dr. Elomina. Please read them very well. But do remember na that handout is not the be-all end-all ng exam ninyo. Okay? The main reference is still Robin. So sometimes, ang nakikita namin reklamo ay wala siya sa handouts. Patandaan nyo, likely nandyan yan sa textbook. Hindi naman namin kasi pwedeng gawin na i-copy-paste ng buong textbook para basahin ninyo dyan. That defeats the purpose of making a summary handout. Kaya the handout is just what it is, a summary of what you're already supposed to know, okay, from pathology in second year med school. Kaya sana nabasa ninyo yung main textbook back when you were in medical school. Pero kung matagal na, then the handout should serve as a parang a review lang, not the parang absolute reference for the upcoming exam. So now we proceed with the different organ systems. First, we deal with the blood vessels. Okay. Question 1. Which of the following diseases can cause aortic dissection? A. Marfan syndrome. B. Ehlers-Danlos syndrome, classic type. C. Cystic fibrosis. D. Churg-Strauss syndrome. And the answer here for this question is letter A. Marfan syndrome. So we first review the difference between aneurysm and dissection. Ang aneurysm, I'd like to think of it as a weakness sa wall ng blood vessel ninyo. So when you are in a state of high pressure, yung weakness sa wall na yun would cause an area of dilation. So magkakaroon ka ng lolobo yung area na yon. And pag nag-rupture na yon, you call it a ruptured aneurysm already. But sometimes it may dissect kung saan ang nangyayari. There's going to be blood tunneling between the layers of the wall. So ang dissection kasi, napupunit siya from the inside. So nagsiseparate ang layers ninyo. Okay? So both of these can actually happen in a setting of Marfan syndrome because of its inherent yung genetic issues niya causing yung mutation niya causing a defect in fibrillin 1. Okay? So yun yung tatandaan ninyo with regards to Marfan syndrome. Okay. Ehlers-Danlos syndrome is partially correct. It has to be the vascular type ang tatandaan nyo ang magkakos ng dissection. Okay. So, aortic dissection, usually it is seen in patients na 40 to 60 years old, usually hypertensive. But if it happens in young patients, like in one of my patients back then when I was an intern, 20 years old lang siya, pero kasi he had Marfan syndrome, this is actually how he died. Ruptured aortic, nagkaroon siya ng aortic dissection already. So its main clinical manifestations is sudden anterior chest pain radiating to the back, and the rupture siya to the blood cavities causing hemorrhagic shock into your patients. Next question. MPO-ANCA is associated with which disease? So this is kinda reverse. Usually kasi may case, diba? Tapos ang tanong sa inyo, ano yung diagnostic test na gagamitin ninyo. Pero sometimes what they may ask is, ano yung diagnostic test, saan siya ginagamit? So this is actually a diagnostic test. And the question sa inyo dito is, where do you use this? So is it granulomatosis with polyangiitis, polyarteritis nodosa, microscopic polyangiitis, or Kawasaki disease? So the answer here is letter C, microscopic polyangiitis. So microscopic polyangiitis is associated with henochon line purpura, and the vasculitis associated with connective tissue disorders. And it's MPO-ANCA related. So, this one is not in your handout. So, this is just a summary of kung saan nyo nakikita yung ANCA or anti-neutrophilic cytoplasmic antibodies. So, these are, from the name itself, these are antibodies that attacks the proteins within the neutrophils. So, ano siya, nandun siya sa cytoplasm. Kaya from the name itself, makukuha nyo na inaatake niya yung neutrophils. And there are two types, the C-ANCA and the P-ANCA, pero those are the old names. So, isa pa yan sa kailangan pa lang, babalaan kayo. I don't know if your examiner is updated. Kasi ang problema kay Robis is actually already quite old. It's already circa 2020 yung textbook. So some of the terminologies have changed, and so I will be mentioning it along the way if there are differences with the current na mga criteria. So C-ANCA, P-ANCA are the old names. Now it's C-ANCA is called PR3-ANCA. You usually see that in granulomatosis with polyangiitis, while P-ANCA or MPO-ANCA is microscopic polyangiitis or Churg-Strauss syndrome. Next, which blood vessels are the most commonly affected in patients with Kawasaki disease? So, most commons usually asked sa mga diseases. So, something to remember when you're going through your handouts. Are these the portal blood vessels, coronary arteries, splenic arteries, or the renal arteries? And the answer here is coronary arteries. So the Kawasaki disease is usually seen in young children, and meron kang antibody na kailangan tandaan. That's your anti-endothelial cell antibodies, and they usually affect the coronary blood vessels. Okay. Other findings na important dito would be your lymphadenopathies. Okay. Yan ang importante. So, because it affects the coronary arteries, the complication that you expect could be MI, of course. Next. Question number 4, 65-year-old male smoker presents with progressive facial swelling, dyspnea, and cough for 2 weeks. He also reports weight loss, fatigue, chest pain. PE reveals dilated veins on the chest wall, neck, and arms, as well as edema of the face and upper extremities. Chest X-ray shows a large right lung mass with mediastinal widening. What is the likely diagnosis of the patient's condition? A. Inferior vena cava syndrome, B. Superior vena cava syndrome, C. angioedema, and D. Cardiac tamponade. So, let's break down this case. What do you have? I think ang pinaka-telling na clue dito, merong large right lung mass. So, ang tanong dito is which of these 4 are associated with masses? So, I think it would be either A or B na lang dito. Okay? Because with large masses, ang isa sa mga mass effects sa kailangan yung tandaan would be compression of the blood vessels, if not outright invade them. Okay? But this time, parang ang nangyayari, more of sa head ang mga findings mo. Dilated veins sa chest wall, neck, arms, edema of the face and upper extremities. So, because mukhang upper body or head ang naapektuhan, it's going to be likely your superior vena cava syndrome. So, the answer is letter B. So, let's differentiate between the two. In superior vena cava syndrome, the setting is usually lung CA or mediastinal lymphoma. Anything that can affect the superior vena cava, of course. So, kung lung CA na paakyat ang growth nila, or because may mediastinal mass ka, may growth siya na pataas in compressing your superior vena cava. And of course, your clinical features would be mostly sa head and neck. Okay? While your inferior vena cava syndrome, usually, kung mapapansin nyo dito, either liver or kidney na tumor ito. Okay? So, clinical features, of course, din ibig sabihin nito, lahat ng lower extremity nyo maapektuhan. So, lower extremity edema, distended lower abdominal vein collaterals, and massive proteinuria. Next, which of the following tumors is associated with von Hippel-Lindau syndrome? So, this one is a topic na nakikita namin recurring, yung VHL na syndrome. Tumors na, so dito, ang question is which of the tumors na napapansin natin are, is it A. cavernous hemangioma, B. lymphangioma, C. aglomous tumor, D. hemangioblastoma? And the answer here is D. hemangioblastoma. So, because of the main mechanism for this is the inactivating VHL mutation. So, meron kang unopposed HIF1 alpha action leading to tumor growth. And dito, ang VHL, usually kasi na-associate natin siya with renal cell carcinoma. Pero ang isa sa mga very important na na tumors to remember is actually hemangioblastoma. In fact, if we go to the WHO, they do have now a separate textbook on genetic tumor syndromes. Ang classic na VHL is actually not sa renal cell CA. However, it's on the hemangioblastoma in the CNS or the retina. Okay? So yun yung isa sa mga cornerstones for the diagnosis, plus another extraneural tumor. So usually this would be your renal cell CA already. Pero any of this here, pwede ka magkaroon under because of the VHL mutation. Okay, so please remember that ang ano for VHL is hemangioblastoma. Next, number 6, 25-year-old male seen due to the presence of multiple violations nodules on the patient's chest. He worked as a sex worker and was diagnosed with HIV the past year. Which of the following statements is true regarding this lesion? Is it A, the cell of origin are modified smooth muscle cells? B, it's secondary to exposure to vinyl chloride. C, it is due to infection of HHV8. Or D, the tumor can regress on its own. So actually, this is one of the recurring topics that we see sa mga previous na exams. I think this has come up already in like the past 2 na exams. So this topic is actually parang maganda siya tandaan dito. So, ang tanong kasi is, ano ba ang diagnosis sa case na to? Okay? So, this is a 2-step question. The diagnosis of this case is likely Kaposi sarcoma because of the violaceous nodules and the history of HIV sa pasyente na to. So, the answer in here is letter C. It is due to infection of HHV8. So, let us review now Kaposi sarcoma. The main etiology is human herpes virus 8 or HHV8 or Kaposi sarcoma herpes virus KSHV. Although the classic finding is the violaceous plaques or nodules, remember that it will start as red purple macules. Meron kang patch stage muna. Madalas kasi yung mga pasyente nakikita na natin in here in the nodule stage na. So, microscopic findings, small slit-like vessels like by mildly atypical cells. Remember na ito ay nanggaling mostly sa blood, this is a blood vessel disease rather than a smooth muscle disease. Okay? So, it may have the presence of these hyaline bodies as well. And you can do an immunohistochemistry stain which would highlight HHV8. However, IHC as a test in here, hindi pa masyadong frequent sa Pilipinas. So, actually, before we go forward, let me just talk a little bit about IHCs. So, because you will encounter that a lot sa pag-aaral nyo ng patho. This is a special method na kung saan we can identify certain markers found in cells with this test. So, ano nangyayari? Yung background namin is kulay blue. And kapag may brown, it means sabihin merong reaction na nangyayari. And we see that under the microscope. So, it's parang exploiting antigen-antibody interactions. So, pero this time, we're trying to detect the presence of certain certain we can do certain viruses as well. Kaya ito HHV8 kaya namin identify using this method. You will see that a lot kasi marami sa mga criteria would be relying on IHCs. Okay. So there are actually 4 clinical forms. You have the classic endemic African, the transplant-associated, and the AIDS-associated na clinical forms. What we have in here now is the AIDS-associated forms. However, sa isang exam, actually, they were asking about non-HIV-related na Kaposi sarcoma. So, just to review, yung classic na profile nyo, usually of European, Eastern European descent, or sa Mediterranean countries, it has an indolent course. Pag sa Africans naman, usually younger than 40 years old, again, not associated with HIV infection. You will see a lot of lymphadenopathies in this patient and it is very aggressive among the Africans. Transplant associated because meron kang T-cell immunosuppression. Please remember that. And then they're easily infected with HHV8. Kaya naging aggressive sila. And then, of course, you have the AIDS-associated na disease already. Okay, so next we're going to be discussing pathologies of the heart. First, which of the following is an example of a right to left shunt? Is it ASD, VSD, PDA, or TGA? Hopefully, sa exams ninyo, buuin nila ito, pero nilagay ko ito para warningan kayo that they may put the acronyms instead. So, ingat lang sa exam. The answer here is TGA. So, actually, while this one is not in the handout, lang siya, sinummarize ko lang kung ano yung mga left to right shunts at mga right to left shunts. So under left to right, that's your ASD, VSD, and PDA. While yung right to left ninyo is tetralogy of Fallot, transposition of the great arteries, and persistent truncus arteriosus. Next, which of the findings in a patient with tetralogy of Fallot is considered as a physiologic consequence of the condition? Is it a ventricular septal defect, right ventricular hypertrophy, overriding aorta, or subpulmonic stenosis? So, remember na in tetralogy, meron talagang yung 3 na absolute findings ninyo, and only one is like parang a consequence of the other 3. And the consequence na finding is actually your RVH. So lahat sila findings ito ha in tetralogy. Pero only 3 are the ones na due to an embryologic reason, and the other one is due to a physiologic reason. So, let's review tetralogy of Fallot. This is also one, actually, congenital heart disease in general, recurring topic siya. So, hindi specific to tetralogy. So, a tetralogy of Fallot is the most common cyanotic congenital heart defect. The main components of that is the large ventricular septal defect, the subpulmonic stenosis, or kung hindi ito, the term that they will use is the right ventricular outflow tract obstruction, the overriding aorta, and the right ventricular hypertrophy, which is your physiologic consequence. Okay? Now, clinical features, in a pink TOF, clinically, your patient is going to be clinically like VSD lang. Pero in a classic TOF, your patient is going to be cyanotic with TET spells. Next, which of the following congenital heart defects is considered as the most fatal? Persistent truncus arteriosus, transposition of the great arteries, tetralogy of Fallot, or coarctation of the aorta. So this one is not outright mentioned sa libro. So you're going to have to read between the lines. The answer here is persistent truncus arteriosus. Okay? So bakit? This is actually lethal without any intervention. Kaya siguro kaya siya tinawag na most fatal. Yun yung term kasi na lumitaw sa previous na exam. Okay. So, ano ang components ito? You have a VSD, a single truncal valve, and a single outflow tract. And unfortunately, these patients are going to be very cyanotic. Mag-mix talaga and the only way that they can survive is the presence of the VSD. Kailangan merong mixing ng blood para meron kang oxygenation na mangyari kahit paano. Pero eventually, magkakaroon ka naman ng isomerization. Kaya hindi ito compatible with survival at all. So you need to do surgery for this patient. Next, which morphologic finding is the earliest to appear in a patient with myocardial infarction? Dark mottling, wavy fibers, neutrophilic infiltrates, or central softening. So in the morphologic findings of MI, microscopic always goes first rather than your gross. So, ang pwede mo natanggalin dito is dark mottling and central softening kasi nga mauuna si microscopic. So, ito na ng dalawa. So, between wavy fibers and neutrophilic infiltrates, it's going to be your wavy fibers. Yung neutrophilic infiltrates, while neutrophils usually denote an acute inflammation, it's actually a few hours pa later, mauuna si wavy, a few hours to days later, mauuna si wavy fibers. So let's check this table out. With regards to the morphologic changes seen in MI, this is also one recurring exam question. So mauuna, as I've said, is the waviness of the fibers. The neutrophilic infiltrates happen only around 12 hours to 1 day already. Dark mottling, 4 hours at least. So, mauuna pa rin si waviness of fibers mo. And the central softening happens already in around 3 to 7 days. Next. 10-year-old boy presents in the ER with fever, sore throat, swollen lymph nodes, fatigue, and shortness of breath for the past week. I think important dito is history of recurrent gas pharyngitis. Gas stands for group A strep. Group A strep pharyngitis and has not taken antibiotics for his current infection. Nag-develop siya ng migratory polyarthritis which is painful and limits his mobility. Physical exam also reveals a friction rub during cardiac auscultation. What is a likely diagnosis of the patient's condition? Is it infective endocarditis, ischemic heart disease, carcinoid heart disease, or rheumatic heart disease? And the answer here is letter D. I think clincher dito yung may previous siya na group A strep pharyngitis. Okay. So, continuing from the previous case, if a heart muscle biopsy is performed, note that it does happen, pero medyo rare to. Which of the following microscopic findings is expected? A. B cells, eosinophils, activated macrophages, or choice B, T cells, plasma cells, activated macrophages. Letter C, B cells, basophils, neutrophils. Or letter D, T cells, eosinophils, neutrophils. And the answer here is letter B, T cells, plasma cells, activated macrophages. So let's review rheumatic heart disease. Usually seen in the pediatric age group, 5 to 15 years of age. So, usually a sequelae of group A strep pharyngitis. So, actually, kaya kasi ko siya sinasabi na very important clue doon sa case na yun. Whenever you're encountering a case, try to pick the very important clues there that could clinch you to the diagnosis. Okay? So, yung morphology niya, it's composed, yung sinabi kong yung set of findings na yun, are actually the findings you usually see in Aschoff bodies, which are T cells, plasma cells, and Anichkow cells. And your Anichkow cells are actually, also known as caterpillar cells, are actually activated plump macrophages arranged in a linear fashion. Kaya siya tinatawag na caterpillar cells. Medyo mahirap siya hanapin, and in some schools that actually have this slide, they know the experience na ang hirap ito hanapin under the microscope. Okay? So, basta tandaan nyo, the Aschoff bodies, itong tatlo, T cell, plasma cell, Anichkow cell, yung Anichkow cells mo are just your activated plump macrophages. Kaya ito yung sinasabi ko na the buzzword is not used, pero instead the description of the buzzword is used. So, clinical features na very important dito is the Jones criteria. It needs 2 major criteria or 1 major and 2 minor criteria. So, what is the major criteria? That would be joints or migratory polyarthritis, the carditis or sa heart, nodules, erythema marginatum, and sydenham-chorea. Pero very important dito, ang actually required for diagnosis is evidence of prior group A strep na infection. You have two choices for diagnostic tests, either ASO or anti-DNase-B. Pero here in the Philippine setting, what we usually see is ASO, the titers na mina-measure for your patients. Okay. What is the most common primary cardiac tumor among children? Rhabdomyoma, myxoma, rhabdomyosarcoma, or leiomyoma. So note ha, especially with tumors, pag mga most common ang tinatanong, malamang magkaiba between the pediatric and the adult stage. So remember that they're asking most common among children, most common pediatric na primary cardiac tumor, that's going to be A, rhabdomyoma. Myxoma would be the answer if this was adults. Okay? So, rhabdomyoma, most common primary tumor of the pediatric heart. It can either be sporadic or familial. Kung ano man, the mutation in here would be the TSC1 or TSC2. Okay? The morphology this is usually seen in the ventricles, and the buzzword for the microscopy would be spider cells. If it's small, it's going to be asymptomatic, pero pag malaki, you do expect some level of heart failure already dahil mag-decrease ang cavity size ng ventricles mo. Pero pag meron kang involvement ng ng conduction system mo, you expect your patients to have arrhythmia. So I guess the best way to diagnose this would be a 2D echo. Well, the 2D echo can say lang kung meron kang tumor, then usually magbabiopsy sila para malaman na rhabdomyoma or outright excision na. Ano, um, for definitive management for this patient. Depende na lang. If it can regress, kung maliit lang, they would let it regress. Pero pag malaki yan at meron ka ng heart failure, baka kailangan ng tapatan ng surgery ito. So that's it for heart pathology. Next, we'll be dealing with WBC, lymph node, spleen, and thymus. Question 14. A 35-year-old woman presented with a 3-month history of painless swelling in the left side of her neck. She had no fever, weight loss, night sweats, or other symptoms. PE revealed a firm, non-tender, and mobile mass measuring 4 by 3 cm in the left cervical region. She was diagnosed with breast CA of the left breast 2 years ago and has underwent mastectomy and chemotherapy and is in remission. Which of the following is the likely diagnosis of the patient's neck swelling? A. Follicular hyperplasia. B. Paracortical hyperplasia. C. Sinus histiocytosis. Or D. Acute lymphadenitis. So, it seems like we have a chronic condition already. And painless siya. So, ang pwede mo nang tanggalin dito is actually letter D. Acute lymphadenitis. The rest of the 3 remaining options kasi is finding seen in chronic lymphadenitis already. So, mukha-mukha kasing ganun nangyayari dito. So, pero ang very important dito is the previous history of the breast CA because only one of these 3 is associated with malignancy or at least a history of malignancy. And that is letter C, sinus histiocytosis. So, lymphadenitis, these are reactive changes sa lymph nodes due to antigenic stimulation. So, for acute non-specific lymphadenitis, of course, you're going to expect a lot of neutrophils and there might even have be pus formation or suppuration in some cases. For chronic non-specific lymphadenitis, tatlo yan. You have your follicular hyperplasia, usually seen in rheumatoid arthritis, toxoplasmosis, and early HIV. Paracortical hyperplasia is usually seen in viral infections. Kaya minsan, di ba, pag nagkasakit ka, kapain mo yung neck, meron ka nakakapangkulane. If you do a biopsy on those lymph nodes, you're going to see paracortical hyperplasia. And last would be sinus histiocytosis, which is usually seen in lymph nodes draining malignancies. Next, which of these hematologic malignancies is considered an emergency? Is it A. Acute promyelocytic leukemia, B. Acute myeloid leukemia, C. Acute lymphoblastic leukemia, or D. Chronic lymphocytic leukemia? So actually, this is again a not stated outright na question na yung hinahanap sa question na to, and you may have to think of the clinical outcomes of the patient based on the given condition, so para makuha nyo yung tamang sagot. The answer in here would actually be acute promyelocytic leukemia. To follow, continuing from the previous question, what is the expected morphologic finding in this disease? So this is an example of those hinging questions in which your answer in here is entirely dependent on the previous question. So yun yung, again, mahirap siya kasi pag mali ka dun sa unang question, mali ka na likely dun sa second answer mo unless nanghuhula ka. Diba? So, for this one, because he answered acute promyelocytic leukemia, the answer in here would have to be D, the presence of the phagot cell. So, phagot cells are basically cells with multiple hour rods. Kasi in Old English, before, that was the time before phagot became a term na degrading. It was a term used for multiple sticks. Ginagamit siya para nagsisiga sila noon. Kaya the concept is the same. Multiple hour rods, marami kang sticks, it becomes what you call a phagot cell. Okay? So, continuing from that, which of the following statements is true regarding this disease? A. It can be seen in conjunction with thymic masses. B. It can transform to DLBCL. C. It can cause disseminated intravascular coagulation. Or letter D. A BCR-ABL1 gene fusion can be detected. And the answer here is letter C, because acute promyelocytic leukemia is associated will cause eventually disseminated intravascular coagulation, and that is actually the emergency the previous question was pertaining to. Okay. So, acute promyelocytic leukemia, the gene fusion in here is the PML-RARA fusion. Okay? At actually, hinahanap yan talaga ng mga hematopathologists natin. And I think only a few institutions can detect this gene fusion. So, morphology na very important is the hour rods. These are needle-like cytoplasmic azurophilic granules that you will see sa promyelocytes natin. And then you will have the phagot cell kung marami kang hour rods na present. You can use MPO o myeloperoxidase to diagnose this, pero usually enough na pag nakakita na kami ng ganito, we don't usually request this anymore para mag-proceed na sa treatment yung hematologist. Tinatawag itong mga kaso na to. Okay. Again, the clinical feature is disseminated intravascular coagulation, and the prognosis is bad unless you are unless you're able to give the medication quickly. These patients are very responsive to a vitamin A derivative known as all-trans-retinoic acid or ATRA. Next, a 12-year-old African boy presents with a large mandible mass and fever. Biopsy of the mass reveals sheets of medium-sized atypical lymphocytes with tingible body macrophages. Many mitotic figures were seen. What is the likely diagnosis? I think the only clue here would be actually helpful pati yung demographic dito eh. African male, large mandibular mass, and this at biopsy finding. So the answer in here is A. Burkitt lymphoma. Okay. So actually this description is the entire description used for dun sa starry sky pattern na sinasabi natin. So the sky in here would be your multiple size atypical lymphocytes. So sea of lymphocytes siya. Then you will see parang areas na clear doon. Those are the stars sa tinatawag. And when you see it closer, those are actually the tingible body macrophages. Okay? So, ano ang importance sa Burkitt lymphoma? Demographic-wise, you usually seen in young patients. Molecularly, you're going to have a MYC overexpression. So, ito actually hinahanap namin for Burkitt lymphoma na diagnosis. And ang main feature nito is a rapidly growing na extranodal mass. Mabilis ito. A few weeks na laki-laki na ng organs ng patients na to. And we usually see them sa mandible. Okay? These are very aggressive pero very responsive to chemotherapy. Kaya kailangan ma-diagnose to ng mabilisan. Next. 65-year-old male with fatigue, headache, dizziness, and itching after hot shower. There's a history of hypertension and gout. Physical examination reveals plethora, splenomegaly, and mild hepatomegaly. Lab tests show a hemoglobin level of 20 grams per deciliter, hematocrit of 60, and decreased erythropoietin levels. A JAK2 V617F mutation was detected in this patient. What is the likely diagnosis? So actually, the clues are kind ang pinaka giving dito na clue for me would have to be the hemoglobin level. These hemoglobin hematocrit levels are highly elevated. Okay? So the answer in here would have to be B, polycythemia vera. Yun actually ang clincher for me. Pero nakakatulong dito is the JAK2 V617F mutation kasi this is part of the essential criteria for polycythemia vera, which I will show later. So, again, the mutation, the JAK2 V617F for myeloproliferative neoplasms. So, for polycythemia vera, your erythrocytes are the ones rapidly proliferating. Kaya, mataas ang hemoglobin hematocrit ng pasyente ninyo. Clinical features would include plethora and pruritus worsen by bathing. When you measure erythropoietin levels, it is going to be low. And if you're going to check the WHO, these are not in the handouts, but this is what's in the WHO. What is the required criteria for diagnosis? You need to have all three major criteria, or first two major criteria plus the minor criterion. Okay, marami pa to, pero I just put in here the subnormal serum erythropoietin level kasi yun yung meron yung patient natin. Pero major criteria, hemoglobin concentration na high, na mataas masyado, or elevated hematocrit. A bone marrow biopsy not done in our patient in this case, pero you will have trilineage growth or panmyelosis. And then the presence of the JAK2 V617F mutation in this patient. Marami pa to itong minor criteria, pero ito nga lang ang nilagay ko kasi yun lang ang meron sa patient natin. So next, we'll be discussing the RBC and the bleeding disorders. Okay, next. 28-year-old male of Southeast Asian descent presents at the clinic for a routine checkup. Blood tests reveal a hemoglobin level of 11, so mababa. MCV of 70, mababa din. MCH of 23. Which of the following is a likely diagnosis? Iron deficiency anemia, hemolytic anemia, Fanconi anemia, or chronic kidney disease. So this is where your knowledge of interpretation of CBC, of our red cell indices rather, come in. Kasi with the interpretation for red cell indices, you already have a differential of what type of anemia your patient has. So MCV low, MCH low. So what you have? Microcytic hypochromic anemia. So, alin dito yung mag-fit sa hypochromic microcytic? So, that's going to be only your IDA. Your hemolytic kasi and chronic kidney disease is normocytic anemia, while Fanconi anemia is megaloblastic. So, this is actually a nice diagram for you to go back to, because it would tell you the differentials of what type of anemia depende sa result ng RBC indices nyo. So you can see here the differentials for a microcytic anemia. So that's tail. Thalassemia, anemia of chronic disease, iron deficiency, or lead poisoning. So, continuing from the previous case, it seems that the patient is not recovering on iron supplements. You are considering thalassemia. Which of the following tests would you like to confirm this diagnosis? Osmotic fragility test, hemoglobin electrophoresis, karyotyping, or peripheral blood smear. So, kung thalassemia to, you want to assess kasi the hemoglobin ng pasyente ninyo. So, you want to do letter B, hemoglobin electrophoresis. So, actually, if you're gonna go back dun sa table na to, yan, for thalassemias, hemoglobin electrophoresis would be the next test that you would want to perform. Anemia of chronic disease, usually history taking ito, makiklinch nyo to, provided na na-roll out nyo yung others. For iron deficiency, you can do your serologic testing dito, TIBC, mga iron binding capacity tests. For lead poisoning, lead testing kasi is not that usual eh. Usually, ginagawa lang yan, special request to na pinapadala sa merong may mass spectrometer. Pero usually, ang isang alternative for the finding out of lead poisoning is do a peripheral blood smear. And you can see findings na semi-specific lang for lead poisoning. So again, hemoglobin electrophoresis is the best answer. So let's review thalassemia. This is common in Asian population. So actually, marami dito sa Pilipinas na mayroong thalassemia. It's likely that you've met a patient na thalassemic tapos nagre-require lang ng blood transfusion bago mo pa uwiin. Okay? So the general pathogenesis is, the main problem of these patients is that there's the deficiency in globin chains, in which kapag meron ka na kasing alteration dito, you're gonna have changes sa what type of hemoglobin your patient has in your patients already. So let's compare between let's go to morphology. Normally, you would have a microcytic hypochromic anemia. If you do your peripheral blood smear, you may see some anisocytosis and poikilocytosis with target cells. Skull X-ray is not that helpful, but you may see a crew cut appearance And then yung may secondary hemochromatosis, so meron kang iron loading sa mga areas na to, sa liver, pancreas, and heart. So when you do an iron stain, you would be able to see yung iron uptake in these cells here. So remember that thalassemia has two types, your alpha and beta. Basically, the way to differentiate them is to kung ano yung gene deletion or gene mutation na nangyari sa pasyente ninyo. Also, your hemoglobin electrophoresis can actually help you differentiate between the two. May mga certain findings that would trigger na, oh, this is an alpha thalassemia likely, and this is a beta thalassemia likely. Kaya, hemoglobin electrophoresis is actually really the test na gusto mong ipagawa. Although for alpha thalassemia, sometimes the mild cases can be difficult to diagnose. Kaya ang ginagawa would be globin gene genotyping already. And although the test is available, I think only one hospital has it right now. Okay, next. 10-year-old male seen in the clinics due to joint problems in the knees and ankles. Maternal and uncle male cousins also have the same condition. PE shows no visible petechiae or purpura. Prothrombin time and bleeding time is normal, but partial thromboplastin time is elevated. CBC and platelet count are normal. Which of the following diagnosis is most likely? So the choices are DIC, disseminated intravascular coagulation, your von Willebrand disease, vitamin K deficiency, and your hemophilia. So I think a major clue dito is that meron kang genetic component already, which is the maternal uncle and male cousins also have the same condition. So so actually of all the diseases in here, I think ang magmamatch lang talaga dito, yung pwede mo natanggalin dito yung DIC tsaka vitamin K. Von Willebrand and hemophilia both have genetic components kasi. So, you can differentiate it based on the bleeding time na lang. Hemophilia has normal bleeding time, so yun yung sagot. So, here. So, between, von Willebrand, di ba, in hemophilia, so ito nga, yung bleeding time ang main difference na lang nila. So, this is a good summary table dun sa mga different bleeding disorders and what are the panel of tests they would request. So, usually, platelet count, bleeding time, prothrombin time, and partial prothrombin time ang i-request mo as an initial. But there are other tests now that can help you with bleeding disorders, pero hindi yan i-discuss. One of the recent na tests would be na thromboelastography, pero that's beyond the normal patho na. Pero that's very helpful kasi in differentiating all of these in a single test. Now we go into pulmopath. Question: a 30-year-old male suddenly develops severe dyspnea with wheezing. PE shows that he is a febrile, pulse of 97, RR of 32, BP of 130/80. Chest X-ray shows increased lucency in all lung fields. Sputum cytology shows Kirschmann spirals, Charcot-Leyden crystals, eosinophils, and some hyphal elements. Which of the following is the likely diagnosis of the patient's condition? So, let's break down the case. So, may wheezing yung patient mo, so likely mayroon kang some sort of bronchoconstriction, kaya ka siya hirap huminga. Ang telling lang dito is medyo mataas ang konting BP niya, pero RR is definitely elevated at 32. Increased lucency in all lung fields in a chest x-ray usually means na meron kang hyperinflation. So, masyadong maraming air, kaya lucent ang nakikita ang findings sa chest x-ray. Cytology though, ang pinaka magka-clinch nito because the Kirschmann spiral, Charcot-Leyden crystals, eosinophils would indicate asthma actually. So actually, ang sagot dito would definitely be asthma. And because you have some hyphal elements, I would be guessing siguro that this patient likely has some sort of allergic reaction na may fungal elements. So that would be like aspergillosis. So, let's go over bronchial asthma. It is a chronic inflammatory airway disease producing episodic variable expiratory airflow obstruction. This is a type 1 hypersensitivity. So, review nyo yung immuno nyo. Ang findings, for morphology, sa patho side na to ha, overinflated lungs. So this is the one that's causing the hyperaeration ng lungs o kaya yung yung lucency dun sa airway. Then when you do your sputum exam, you will see your Kirschmann spiral, which are extruded mucus plugs, and then your circulating crystals, which are made up of galactine 10 from eosinophils. Next, for microscopic findings, you may be able to see some bronchial wall muscle hypertrophy, hyperplasia, vascularity, goblet cell hyperplasia, and then some membrane fibrosis. Ang distinct findings would have to be chest tightness, dyspnea, wheezing, and cough. Siguro ang siguro kung if you see a lot of asthma patients, ang pinaka-ano dito would be the wheezing, ang pinaka-important na physical na PE finding ninyo. Next, you have a 65-year-old man with a history of DM and COPD admitted to the hospital with fever, cough, and dyspnea for 3 days. P showed a temperature of 38.5 degrees Celsius, pulse of 110 beats per minute, BP of 150/90, RR of 28. He had crackles and decreased breath sounds in the right lower lung zone. Sputum gram seen revealed the presence of gram-negative rods. Which of the following is a likely etiology of the patient's condition? So actually, napansin namin sa previous awards, maraming yung mga questions that they're asking etiology and etiology ng disease. So number one, you need to find out kung ano yung disease na meron yung pasyente ninyo, kung case ito, katulad ito, or ang nangyayari is bibigyan nila yung actual na sakit, tapos ang tanong is etiology, na ang pagbabasihan ay siguro may demographic. Ang mas masaklap minsan is merong source na actual silang gusto na pagbabasihan like CDC. So yun yung medyo worry. So whenever you see sa handout na merong specific na parang source kung saan yung yung mga most common na ganyan, it's because lumabas sa feedback from the previous exams. So dito, likely etiology of the patient's condition. Ang magiging clues nyo dito usually is ano yung meron ng pasyente ninyo. So you have an elderly patient na mukhang chronically ill already. Okay? So that's not much to go on kasi marami kang naman differences from elderly. The sputum gram stain may help. Gram-negative rods kasi ang nakalagay. So, alin dito ang siguro pwede mong matanggal based sa sputum gram stain mo? Ang siguro matatanggal mo lang would be Moraxella. Because Moraxella is a gram-negative Diplococcus while all the other three, Pseudomonas, Legionella, and Klebsiella, would be gram-negative rods. Okay, so ang natanggal mo lang doon isa. So between the three na lang ngayon, ang tanong na lang dito is ano yung specific for the elderly? Elderly lang ha, kasi may mga caveats yung iba eh. And the answer here would be D, Klebsiella. So this is a table from your handout showing the different etiologies of your community-acquired pneumonia. So let's just go dun sa choices natin. For Klebsiella, most common cause of gram-negative bacterial pneumonia. For Pseudomonas, while it is usually associated with your mga immunocompromised, ang very important sa demographic kasi would be hospital-acquired infection. So dapat ang lumabas sa history ninyo is admitted yung patient nyo for a long time, then suddenly nag-develop ng pneumonia. Yun. O kaya, the patient long-standing na admitted, pinauwi, then bumalik because of pneumonia. Yun yung maging history nyo. Legionella, patients with comorbidities, pero I think ang mas importante dito would be the fact that it's seen usually in organ transplant patients. Yun yung magiging niya. Kasi unfair kung comorbidities, marami masyado magiging differential. They are likely going to ask the organ transplant if it's going to be Legionella ang sagot nyo. Next, continuing from the previous case, may pleural effusion na nag-develop sa patient na to nakita via X-ray. Thoracentesis was performed. If the lab tests were done on the fluid, yung pleural fluid natin, which of the following results are to be expected? So, ang sakit ng patient, diba, is community-acquired pneumonia. So, this is likely, ang plural effusion nito, kung between transudative or exudative, this is likely going to be an exudative type of an effusion, type of a fluid. So, kailangan yung answer na babagi doon would be characteristic of an exudative pleural fluid. So, alin dyan? That would be letter B. Pleural fluid, serum protein ratio of 1.0. So, helpful dito would be the Light's criteria to determine if it's something is transudative or exudative yung ano mo, ang fluid mo. But there are also other characteristics that can help tell you na outside of this na ano kung transudative or exudative. Ang isipin nyo sa transudative, malabnaw siya kasi usually it's due to to, let's say, heart failure, ganyan. Whereas, so exudative, mabibigat yan. Usually, merong kasamang cells yan. So, it's usually coming from, that your exudative is going to come from infections o kaya malignant pleural effusion. Okay? So, this is yung other findings na outside of the Light's criteria in order to determine. So, as I said, exudative, mabigat. So, in specific gravity, dapat mataas yan. And mataas ang protein content ng fluid. Ganon ko siya tinatandaan. Exudative, mabigat. Transudative is very light na fluid. Okay, next. So, may continuation na naman. Which of the following mechanisms would explain the presence of pleural effusion? Increased capillary permeability, decreased capillary permeability, increased capillary oncotic pressure, decreased capillary oncotic pressure. And the answer here is letter A. So again, ito yung mga example ng cases na yung sequential type na kailangan alam mo yung mga sagot sa previous o kaya at least kung hindi outright yung sagot ng previous, at least yung diagnosis ng case para makapag-proceed ka sa on how to think dun sa subsequent questions mo. So this one, increased capillary permeability is the reasoning for pleural effusions behind yung secondary to pneumonia. So I ask you now to just go over this table. Next, we have a biopsy performed in a 65-year-old male with a history of heavy smoking, currently with persistent cough, hemoptysis, weight loss, chest pain, dyspnea, and fatigue. Chest X-ray shows large mass in the right hilum with mediastinal widening and pleural effusion. Microscopic findings show small cells with scant cytoplasm, molded nuclei with salt and pepper chromatin, increased number of mitotic figures in areas of necrosis. What is the likely diagnosis of this lesion? Now, if you are medyo astute ka sa mga findings sa microscopic, you can actually already clinch this tumor. Pwede mo na matanggal itong dalawa automatic. Itong si adenos CA at squamous cell CA. Although squamous cell CA is associated with heavy smoking, hindi babagay sa kanya kasi yung microscopic description na small cells with the nuclei, salt and pepper chromatin. So the answer in here is letter C. Okay? Yung small cell carcinoma na. Between small cell carcinoma and carcinoid tumor, both kasi would have the salt and pepper chromatin. Pero pag meron ng increased number of mitotic figures in areas of necrosis, that should point you towards the diagnosis of a small cell CA rather than a carcinoid neuroendocrine tumor. These kasi are very well-behaved tumors. So let's just go over small cell CA. Third most common histologic type, usually central in location. Association with smoking almost always. And ito yung morphology niya. So I just verbatim lang ang microscopic description. Tandaan nyo ha, kung gagamit man yung mga examiners ng mga gross and microscopic descriptions, it's likely going to be verbatim Robbins. Okay? Is there a precursor lesion? Wala. Sa akin, ang mutations, T53RB can be similar with the other types of tumors. So, pero IHCs, you would need synaptophysin and chromogranin to clinch a diagnosis. Okay. Next. What is the initial inciting event behind acute respiratory distress syndrome? Injury to the pneumos and endothelium, neutrophil adhesion and extravasation, formation of hyaline membranes, or secretion of TNF to the endothelium. So, I think there's no shortcut to this. Just you need to understand how ARDS happens. So the answer here would be letter A, injury to the pneumocyte and endothelium. So let's just go over. ARDS has many different etiologies. So remember, this is a sequelae of your initial na inciting agent. So it can be a diffuse pulmonary infection or sepsis or even as simple as gastric aspiration. Pathogenesis, your initial inciting would have to be your endothelial alveolar epithelial injury, followed by edema, recruitment of neutrophils, followed by inflammation, and then cell death. Okay? In sa microscopic findings, ang pinaka-important na finding dito would be hyaline membrane formation. Okay? Yan kasi ang pinaka main na finding common consistent finding sa mga pasyente na namatay because of ARDS. Okay. And that's for pulmopath. Next, we go into head and neck. Next question. Low-risk HPV is associated with which of the following head and neck tumors? Nasopharyngeal carcinoma, nasopharyngeal angiofibroma, sinonasal papilloma, or reactive laryngeal nodules. The answer here is letter C actually, sinonasal papilloma. So, sinonasal papillomas are usually seen among males around 30 to 60 years of age. There are three types. Yung exophytic, inverted, oncocytic. I think yung pinaka-importante dito is the inverted type kasi among of the three types, siya yung although it's benign in nature, it's it can invade yung yung mga buto. So locally, kaya siya locally aggressive eh. Kaya yan, when yun, pag kailangan i-excise yan, kailangan buo tanggalin yan para hindi siya mag-recur. Okay, very important yung association with low risk HPV 6 and 11. And on microscopic findings, but this is the inverted type eh. These are nests of hyperplastic immature squamous cells invaginating to the underlying stroma. So nagkakaroon ka ng maraming parang islands or nests of these immature squamous cells doon sa stroma ng tissue mo. Next. 54-year-old male smoker seen in the clinic due to enlarging mass on the right cheek. PE shows that it is around 3 cm wide, firm, mobile, and painless. Oral mucosa is normal, no difficulty in chewing and swallowing. Biopsy revealed a neoplasm with a stroma filled with lymphocytes lined by a double layer of oncocytes. What is the likely diagnosis? So, if it is firm, mobile, and painless, I think it is safe to say na pwede mo nang i-rule out lahat ng mga CAs mo. Kasi if this was CA, it's going to be immobile. Mahirap galawin kasi nag-invade siya into the surrounding structures. Remember the head and neck. Sa head and neck kasi, ang pinaka-problem nyo is the proximity of each organ to the adjacent organ. So, magkakalapit. For CAs, madalas na, unencapsulated tumors and will easily invade the surrounding structure. So, magiging immobile na yan dapat. So, between pleomorphic adenoma and warthin tumor, ang magiging clincher na dito would be the biopsy. Lymphocytes, double layer of oncocytes, that would be your warthin tumor. Your pleomorphic adenoma kasi would be your ductal cells, may epithelial cells, tapos yung chondromyxoid matrix. So, answer is letter B. Warthin tumor. It is the second most common salivary gland tumor associated with smoking. Most common site parotid, almost exclusive. Actually, one of the nice things to study din kapag if we're differentiating the salivary gland tumors, it's the location. So ito cheek, so isipin nyo parotid gland. So siya, mas mag-isip kayo ng warthin dito. But it also helps na sobrang telling ng findings sa biopsy niya na mayroon kang lymphoid stroma, double layer of oncocytic cells. Next, we have GI patho. Okay, so for GI patho, this is actually one of the sections ng patho na medyo high yield. By history, napakadaming lumalabas dito. maraming topics na sinasama nila sa exam at paulit-ulit actually over the several board exams na nagtuturo ako. So, let's go over GI path. So, first, we have a 4-week-old male infant presenting with a history of projectile non-bilious vomiting after feeding for the last week. He appears hungry, irritable, and has lost weight. Abdominal palpation reveals an olive-shaped mass in the right upper quadrant of his abdomen. What is the likely diagnosis of this patient? Gastric CA, esophageal atresia, pyloric stenosis, or tracheoesophageal fistula. Now, because the history is kind of telling na mayroong olive-shaped mass, you can actually remove atresia and fistula. Although these are known na causes also of non-bilious vomiting. So, ang choices mo na is gastric CA versus pyloric stenosis. Between the two, ang unlikely naman na magkaroon ka ng gastric CA is isang 4-week-old na bata. So, likely the answer here is going to be pyloric stenosis. So, pyloric stenosis, or the full name is congenital hypertrophic pyloric stenosis. It's associated with Turner syndrome, trisomy 18, and macrolide exposure the first 2 weeks of life. So, this is actually parang exposure disease usually, or associated with a congenital anomaly. So, the main morphology is that there's a hypertrophic muscularis propria in the pyloric region, and that is the one na napapalpate nyo already as a mass. So, ang nangyayari, yung pylorus ng pasyente, sobrang kapal na nito to the point na hindi siya makapag-accept ng food. That's why your patient will be presenting with regurgitation and non-bilious vomiting. Treatment of this will be cutting out that segment, so also known as myotomy. Next, which of the following esophageal lesions is a component of Plummer-Vinson syndrome? Unfortunately, they are going, madalas na nakikita namin is they are giving you syndromes na hindi likely unfamiliar kayo kasi hindi naman to nakikita sa clinics at all. So, you have no choice but to be familiar with them. So, which lesion? Is it esophageal rings, web, stenosis, or achalasia? That is esophageal webs. But hindi lang ito yung component niya. You have other components of Plummer-Vinson syndrome, which includes your iron deficiency anemia, glossitis, and cheilitis. Next, a 55-year-old male with an endoscopy due to recurrent heartburns for the past 6 months. Endoscopist noted a red velvety mucosa along the gastroesophageal junction. Biopsy of that mucosa reveals intestinal metaplasia with goblet cell formation. Which lesion is at risk of developing should this condition not be treated? So, this is a 2-step question. So, the first question in here is, what is the likely diagnosis? So, this is likely Barrett esophagus because of the red velvety mucosa and the intestinal metaplasia with goblet cell formation. Actually, while in Robbins, kasama pa si goblet cell formation, kung intestinal metaplasia lang, okay lang din siya as Barrett's kasi in some countries, yun lang ang kanilang criteria for calling it na Barrett. Also, ang isa sa possible buzzwords na associated with Barrett esophagus is yung salmon-colored tongues na description for the mucosa of the patient. So, Barrett esophagus, that is a risk factor for getting adeno-CA. So, the answer here is adeno-CA, okay? So, Barrett esophagus, dito nga sa handout niyo, intestinal metaplasia lang, wala na yung goblet cells mo. And again, red velvety mucosa, goblet cells dysplasia, kailangan to manote kasi nga, pag merong dysplasia, there is a likelihood already of progressing towards adeno-CA. Next, 52-year-old male with the history of alcohol abuse presented to the hospital with jaundice and abdominal distension, reported drinking heavily for over 20 years, revealed elevated liver enzymes and decreased albumin levels. Liver biopsy shows regenerative hepatocytes arranged in nodules separated by dense bands of fibrosis. So, what is the likely diagnosis of the patient's condition? So, dito actually makukuha mo na regenerative hepatocytes arranged in nodules separated by dense bands of fibrosis. They are describing cirrhosis. However, there can be made a case for alcohol liver disease kasi nga may history siya of alcohol abuse. However, there are by the liver biopsy wala siya yung distinct findings. Okay, so between actually mahirap to sa exam kasi there are two clear possible answers, pero ako I would go for cirrhosis first kasi by biopsy yun ang obvious na sagot dito. Wala pa yung hindi pa sure if talaga nga bang alcoholic liver disease yung cause ng cirrhosis ng pasyente mo. Okay. Continuing from the previous case, a few weeks after admission, the patient developed hematemesis and melena. Which of the following complications might have occurred? Esophageal varices, esophageal webs, angiodysplasia, or peptic ulcer disease? The answer here would definitely be esophageal varices. Okay? Remember na ito ay consequence ng portal hypertension. So, in chronic liver failure or cirrhosis, ang importante dito is the pathologic finding of having your regenerative nodules surrounded by your fibrous bands with variable degrees of vascular shunting. Note, however, that cirrhosis has been, while previously, pag sinabing cirrhotic liver, it's already considered as end-stage liver disease. Not so true now with our new knowledge on cirrhosis. Research has shown na if you yung pag tinanggal mo yung cause ng cirrhosis sa pasyente mo, actually merong certain percentage na magre-recover ng konti yung liver mo. Hence the term regenerative nodules, kasi nagre-regenerate nga yung liver. Etiology, here in the Philippines, ang common na cause would be still infectious in origin. That would be hepatitis B and C and your fatty liver disease. For gross, of course, you will see na very nodular na yung liver mo and with some scarred areas. Microscopic findings, ito na yung description na sinabi ko kanina. Clinical features can be asymptomatic in 40% of cases, pero ang pasyente mo, if symptomatic, jaundice, pruritus, encephalopathy, coagulopathy, hyperestrogenemia, and hypogonadism. Okay. So, maging cause of death though, very important is esophageal variceal bleeding. So, ang problema nito, pag nag-cough ang pasyente, magiging hematemesis ang pasyente, tapos yun na pala, may varices na yung pasyente mo. So, they need to do rubber band ligation or some other therapy para maiwasan ng bleeding. Kasi most likely, ito yung magiging cause of death ng pasyente mo kung hindi siya makuha ng iba. Now, for varices, these are dilation of esophageal portocaval anastomosis due to portal hypertension. So, yun yung requirement for you to have esophageal varices. Portal hypertension. How do you have portal hypertension? Likely due to liver cirrhosis due to alcoholic liver disease. Next, which of the following virulence factors of Helicobacter pylori is associated with the formation of gastric adenoCA? Flagella, urease, CAG-A, or adhesins? The answer here is letter C, CAG-A. Unfortunately, ito nga yung nakikita namin sa feedback from the previous exams that there are stuff from microbiology that bleeds into the pathology exam. So, kailangan wag mong itatapon again yung alam ninyo from micro at i-apply nyo siya dito sa patho exam ninyo. Okay. So, Helicobacter pylori gastritis, most common cause of the chronic gastritis. Your etiology, of course, is Helicobacter pylori with the following virulence factors. Okay. CAG-A is the one that's associated with multifocal atrophic gastritis, and that's the one that leads to gastric adenoCA. For diagnosis, however, very important is the urease kasi that is the basis for the testing. Kaya ang 'di ba ang testing natin is the rapid urease test na nagiging pink pag naging positive, pag nagiging pink yung yung solution kapag pag positive ang test. So, how do you diagnose this? You can do antibiotics to H. pylori, uncommon. Ang usual na ginagawa is the rapid urease test or the biopsy, tapos magre-request ng special stains, usually GIMSA here in the Philippines. Next, which of the following gastric conditions is associated with megaloblastic anemia? Helicobacter pylori gastritis, autoimmune gastritis, gastric adenoma, or gastric neuroendocrine tumor? The answer here is autoimmune gastritis. So actually, very important siya na maimbestiga. If your patient has megaloblastic anemia on CBC, then the clinicians should do a biopsy and check kung mayroong atrophic gastritis ng pasyente. Okay. So, the autoimmune atrophic gastritis is associated with type 1 DM, Hashimoto's, Addison's, and Graves. Your main etiology is the autoimmune destruction of your parietal cells. Kung autoimmune to, malamang meron kang antibodies, that's against your HK-ATPase, yung proton pumps mo, and intrinsic factor. Okay. Pathogenesis, the destruction of your parietal cells causes decreased gastric acid with increased gastrin, and the decrease in the intrinsic factor leads to decreased vitamin B12 absorption, causing your megaloblastic anemia. So, the main symptoms of your patient are mostly related to the B12 deficiency. Next, which of the following bacteria is associated with turista? Now, this is one of the questions na actually hindi namin makita to sa Robbins, okay? So we had to do some external research para malaman kung saan to nanggaling tong term na to. So, ang choices mo is enterotoxigenic E. coli, enterohemorrhagic E. coli, Salmonella typhi, or Shigella. So, the answer here is A, enterotoxigenic E. coli. So, the question is, ano ba yung turista? Okay, so this came from a paper circa 1962. Note, ganun kaluma yung term na to. This is also known as traveler's diarrhea. So actually, the term in Robbins na ginagamit is traveler's diarrhea. Other terms that you may encounter would be Montezuma's revenge, Aztec two-step, Delhi belly, GP tummy, Casablanca crud, or other synonyms for nakuha mo to during travel, usually in a tropical country. Okay? So, ETEC or enterotoxigenic E. coli is the principal cause of this traveler's diarrhea. Okay? So, yun ang pinanggalingan ng term na to. Kaya mag-ingat. Minsan, I don't know kung saan kinukuha ng mga examiners ito or it's showing their age kasi no one uses this term anymore. Next, a 27-year-old Caucasian female was seen at the clinic due to recurrent diarrhea and weight loss. Diarrhea is aggravated whenever she eats bread products or wheat-based cereals. Which of the following statements is true regarding this condition? A. Histologic findings consist of intraepithelial neutrophils, villus hyperplasia, and crypt hyperplasia. B. Serologic presence of anti-endometrial antibody is the most sensitive test. C. If the patient has normal biopsy findings in the duodenum but is positive for serologic studies, this is consistent with silent disease. Or letter D. Diagnosis requires the presence of histologic findings and positivity to serologic studies. Clue nyo, Caucasian female, and then the aggravated ang kanyang diarrhea whenever she eats bread products or wheat-based cereal. So this is actually gluten enteropathy, also known as celiac disease. So, which of the following statements is true regarding celiac disease? It is letter D. Okay? It requires presence. The diagnosis would require a combination of histologic findings and positivity to serologic studies. So, let's go over celiac disease. So this is common usually in the 30 to 60-year-old age, usually seen in females. Etiology is gluten intake. Okay? So medyo complicated yung pathogenesis nito, but the parang summary nito is their sensitivity to the alcohol soluble portion of gluten known as gliadin, and there will be an autoimmune attack against the intestine. Tapos meron kang venous atrophy causing your malabsorption, causing the diarrhea of your patient. Ang pinaka-morphology niya is venous atrophy and crypt hyperplasia. Other findings, so aside from diarrhea, will be bloating and fatigue. There may be some degree of anemia and a skin lesion. Treatment is changing the diet to a gluten-free disease. Kaya nauso ang gluten-free diet. But unfortunately, there are some misconceptions regarding the gluten-free diet. Akala parang supposedly better always ang gluten-free, but not always so. Only those patients na mayroong totoong celiac disease should be affected na with intake of a gluten-filled diet. Hindi sila yung hindi yung nagre-react talaga when eating bread. Okay? So how do you have a gluten-free diet? You need to substitute all of them with some of these examples. Kaya mahirap ang diet nila dahil maghahanap ka ng alternative, tsaka usually mas mahal. Okay. So there's a risk for malignancy, usually enteropathy-associated T-cell lymphoma or small intestine adeno-CA. Pero between the two, mas common dito would be lymphoma rather than adeno-CA, especially sa small intestine. Okay. So this one is taken from my personal lecture. So note nyo na lang ito kasi medyo basic yung nandun sa handout. So I'm not sure kasi how in-depth. So sana hindi sila magtanong nito kasi sa totoo lang, hindi kami nakakakita ng celiac disease dito sa Pilipinas. The only time that I was able to see celiac disease in a biopsy was when I had a foreigner patient. Ganun siya ka-uncommon, kaya rare na diagnosis dito sa Pilipinas. Pero siguro kung magpa-practice kayo like in the US, this is a very important disease to be very very familiar with. Histopathologic findings would include intraepithelial lymphocytes, crypt hyperplasia, venous atrophy. Other cells would include your plasma cells, mast cells, and eosinophils. And very important is yung intraepithelial lymphocytosis, kasi even in mild cases of celiac disease, ito usually ang finding mo. These two findings usually seen in more severe cases. So, ito yung mga differences in adult and pediatric celiac disease. For serologic testing, ang very important is the IgA antibody to tissue transglutaminase, anti-TGA. That is the most sensitive test that you can use. Okay. And actually available siya only in a few select institutions here in the Philippines. Itong anti-endometrial antibody not present so much. Next, which of the following features favor diagnosis of Crohn's disease? Now, this one is a favorite topic among the previous exams. Parating there's some version of this question that appears na parang they're always comparing Crohn's to ulcerative colitis. So, the main take home is be familiar with inflammatory bowel disease. So, your options here for this question: deep knife-like ulcers, diffuse distribution, absence of fistula, or absence of fibrosis. The answer here is letter A, deep knife-like ulcers. So, in IBD, the quick, parang ang pinaka-summary niyan na mabibigay ko sa inyo is Crohn's disease, patchy ang involvement, pero transmural. So, the entire thickness of the colon will be affected in Crohn's. Pero, nagsiskip siya ng area. In ulcerative colitis, diffuse involvement siya. Almost always may rectal involvement ka, pero sa ibabaw lang siya nakaka-apekto ang ulcerative colitis. Okay? Usually, we do see this in the Caucasian population, pero we are seeing cases na rin dito sa Pilipinas. So, we don't know if this is secondary, is parang related ba dito yung shifting diet natin to a more parang to a Caucasian diet. So that's a question up to now. Pero the main ang pinaka pathogenesis yung nakikita is something regarding to chronic mucosal activation in injury. There's also autoimmune involvement. So actually medyo multifactorial itong IBD natin. There are common findings between the two, okay? Hindi sobrang distinct yung dalawa. Common findings would include inflammatory infiltrates, so usually neutrophils and eosinophils, and then your crypt abscesses. So within the crypts, namumuo talaga yung mga neutrophils mo. Other changes that would indicate chronicity would be crypt distortion, so nagmumukhang animals na sa biopsy, yung mga crypts, and then metaplasia. Usually we see panel cell metaplasia. Kung meron kang non-caseating granulomas, that is usually pointing towards Crohn's disease, pero it's only seen around 30% of the time. So it's not reliable during biopsies. Why do you want to monitor these patients? It's because there is colitis-associated neoplasia that you are worried about. So, again, pag sinabing Crohn's, it's going to be skip lesions pero full thickness. Okay? Skip lesions, full thickness, marked fibrosis, marked lymphoid reaction, deep knife-like ulcers, granulomas, yes, only around 30 to 35%. Ulcerative colitis, diffuse pero sa ibabaw lang. So, diffuse involvement, continuous yan, usually rectum plus colon, then, sa ibabaw lang yung involvement, limited to the mucosa, and kung meron mang ulcer, superficial lang. So, clinical, the fistula formation definitely includes kasi nga transmural disease siya. And yung malignant potential usually seen in ulcerative colitis. And sa Crohn's, meron siguro po only those sa sa involved areas. Next, which of the following polyps has the greatest potential to transform into a carcinoma? Hyperplastic polyp, fundic gland polyp, inflammatory polyp, or villus adenoma. So actually, the question here is which one of these is neoplastic polyp versus a non-neoplastic polyp. Okay, so between the polyps, itong tatlo, hyperplastic, fundic gland, and inflammatory polyps are all the non-neoplastic. Villus adenoma is the only one that's neoplastic here, so that is the answer to this question. So, your conventional colorectal adenomas, they may have three types of architecture, tubular villus or tubular villus architecture. With the villus architecture, the most highest possibility of progressing towards a carcinoma. Dysplasia is always present. Minimum is low-grade dysplasia, pero pag mayroong high-grade dysplasia, that is reportable already. The bigger the polyp, the higher the risk of it is being malignant. Kaya on endoscopy, pag may nakitang polyp, sample yan agad kasi gusto mo makita kung low grade lang siya or meron ka ng carcinoma. Sometimes, there in some high-grade lesions, there may even be what you call an intramucosal carcinoma. So, CA na siya sa labas lang, pero dahil niresect ang polyp, at yung polyp na yung resection margin ay negative for tumor, then considered as treated na yung pasyente ninyo. Okay, so that's for GI path. Next, liver, gallbladder, and pancreas. Question, which of the following morphologic findings would indicate that the liver tissue is undergoing repair? Ductal reaction, cholestasis, ballooning, or presence of Councilman bodies? The answer here is letter A, ductal reaction. So, ang iba kasi ang liver compared to other parts of the body. May mga specialized cells kasi sila. So, each of those cells would react differently to what type of injury na meron yung patient mo. Actually, ang ganito ay mostly si liver tsaka si brain. So mamaya dumating na tayo sa CNS, so we'll be discussing the different responses ng cells to injury. For reversible injury, what you usually have is steatosis, cholestasis, or ballooning. Yung steatosis, ibig sabihin na nito, you're getting a lot of fat cells sa para nagkakaroon siya ng fatty accumulation sa parenchyma mo. Cholestasis, meron kang bile uptake sa loob ng mga cells mo. So makikita mo sila as parang brownish material within the hepatic parenchyma. And then yung ballooning mo, meron kang cellular swelling. For irreversible changes you're going to see necrosis and apoptosis. And in apoptosis, you're going to see either acidophil bodies or councilman bodies. For repair, you're going to have regeneration, which is what you see usually sa cirrhosis, yung mga regenerative nodules, yung as I mentioned kanina, and then yung ductal reaction, yung kasama sa choices natin, and scar formation. In ductal reaction, dito dumadami yung mga bile ducts mo. So normally, in your portal tracts, you're going to have only around a maximum of 2 na bile ducts. But in ductal reaction, more than 2 na sila. Next, a laboratory result of a patient with the following hepatitis B profile was seen in your clinic. And positive anti-HBs, positive IgG anti-HBC, negative HBsAg, negative HBAg, and negative anti-HBe. How would you interpret this result? Is it acute infection, window period, recovery from infection, or immunization after vaccination? So, dalawa yung positive mo, IgG anti-HBC and anti-HBs, which would mean your patient is likely recovering from an infection. So actually, ito yung isa sa mga nakita kong difficulties in some students, yung interpretation of the hepatitis B profile. Kasi among the different hepatitis viruses, ito yung parang may expanded na profile, hindi katulad ng iba. So in serology, you usually have these 6 markers, although actually 5 because HBsAg is not measured routinely. So, para for me kasi it's better for you to understand kung ano yung ginagawa ng kada test, yung the logic behind the test, rather than memorizing what it simply does. So, HBsAg, sa surface, ang clue mo lang dyan is HBs. Okay, always may S ka. For core, HBC. Envelope, HBe siya. So for surface, yung antigen mo, kapag present, ang tanong dito would be, is the patient currently infected? If positive, if patient is currently infected, then positive dapat ang HBsAg mo. Or sa antibody naman, has the patient recovered from infection or is the patient immune? So, pag positive ito, ibig sabihin, kung, for example, nagpabakuna ang pasyente mo, then dapat positive ka dito, negative ka dito. What you would notice actually is that for itong dalawang to, it's either positive ang isa at negative yung isa. Hindi sila pwedeng sabay na positive hindi sila pwedeng sabay na positive, yun. Okay? Pwede ka maging negative na sabay kung never been infected, never been vaccinated. Yun, okay? Next, core. So dito, ang mini-measure lang is the antibody. So has the patient been infected at some point? So dito, kung IgM ka, IgM mauuna, IgG yung huli. Diba? So IgM kapag acute infection meron ka, pag IgG, chronic infection ka. For envelope, the antigen would be asking if the patient is actively infected, which means that the viruses are currently replicating. If they are currently replicating, then therefore, positive ka for the HBe antigen. Pag anti-HBe naman na meron ng patient, it means that your patient is likely starting to recover. Okay? So how do you convert this to the table that you usually see sa mga textbooks niyo? So maging ganito siya. Okay? So, again, tingnan niyo yung relationship ng HBsAg sa anti-HBs. Usually, yung isa positive at isa magne-negative. The only time na negative sila pareho would be this window period or never been infected in the first place. Okay? So, yan yung makikita niyo yung relationship na yan. Then, look at anti-HBc. Remember, ang tanong niya is, naging infected ba siya at some point in time? So, pag IgM, recent infection, pag IgG, chronic infection na siya or may recovery ka na. HBeAg, ang tanong dyan is kung actively replicating. So kung may active infection ka, it's likely going to be positive. Okay? Anti-HBe, ibig sabihin nito, recovering na yung pasyente mo. So usually nasa chronic phase siya mo makikita. Okay? So that's how you understand the logic between the different hepatitis serology tests. Next, 25-year-old female presented with progressive difficulty in speaking and writing for the past 6 months. May tremor siya sa hands and legs. Noticed a brown-green ring around her irises. So ito very important clue yan dito. History of recurrent jaundice and abdominal pain since childhood. Family history revealed that her maternal uncle had died of liver failure at age 30. On exam, meron sa signs of liver cirrhosis, immunological impairment. What is a likely diagnosis of this patient? So actually dito, siguro ang pinaka-helpful na clue sa akin dito would definitely be this brown-green ring around her eyes kasi medyo distinctive siya. So the answer here would be Wilson disease. So, continuing from the previous case, which of the following trace elements is heavily involved in the pathogenesis of this disease? Is it iron, manganese, copper, or zinc? And because Wilson sasagot natin sa previous, the answer is copper. So what is Wilson disease? What happens in Wilson is that there is decreased copper incorporation into the bile, causing decreased ceruloplasmin and increased tissue copper. And that in the copper na metal backflows into the blood, and that will be causing yung kung ano man ang findings sa pasyente natin. And that would also cause increased urinary copper excretion. So ano mga main findings natin? In the liver, medyo variable, pero you would end up with cirrhosis. In the brain, you would have caudate and putaminal atrophy. In the eye, ang very important is the Kayser-Fleischer ring. Yan yung green to brown deposits in the descemet membrane in the corneal limbus. So sa gilid lang siya ng cornea mo, makikita mo yung brown-green ring na ito. Okay? So, so how do you diagnose this? Usually ang ginagamit na for enzymes like this would be mostly I've been seeing ceruloplasmin detection, pero actually ang pinaka magandang test would be getting biopsy samples, then sending it to institution with mass spec, then do dry weight tissue copper measurement. Ito yung increased hepatic copper. Yun, dry weight hepatic copper ang pinapatest specifically. Next, which autoantibody would you request if you want to confirm the diagnosis of primary biliary cholangitis? Is it anti-mitochondrial antibody, anti-neutrophil cytoplasmic antibody, anti-double-stranded DNA, or anti-phospholipid antibodies? The answer here is letter A. Walang clue, rote memorization ito, unfortunately. So, with PBC or primary biliary cholangitis, remember it has associations with other autoimmune diseases because it is an autoimmune disease in itself. Meron kang T-cell mediated attack on the small interlobular bile ducts causing bile duct injury, and eventually, kapag napabayaan, will lead to cirrhosis. We have two autoantibodies present, that's your anti-mitochondrial antibody or ANA. Pero ang problema kasi with ANA, it's too non-specific. So, unfortunately, some laboratories do offer measurement of AMA already, so you can use that to request for your patients. Next, oral contraceptive pills are associated with which liver lesion? Is it FNH, hepatocellular adenoma, angiosarcoma, or hepatocellular carcinoma? The answer here is letter B, hepatocellular adenoma. So, you have 3 subtypes nito based on its molecular features. Pero actually, even among the different molecular features, meron silang specific microscopic findings as well. Ang importante with hepatocellular adenoma is its association with the oral contraceptive pills. Okay? Yan. On gross, there's always a distinct mass with hemorrhage formation. So, pag nag-resect, dapat makikita mo yung interface between the normal liver parenchyma and the hepatocellular adenoma. Then, on microscopic findings, makikita mo would be hepatocyte plates, and because you're inside the tumor, you should not be able to see interlobular bile ducts or portal tracts. Okay? Dapat, usually sign yan na kapag may portal track ka, ibig sabihin you are in normal liver. Pag wala kang nakikitang portal tracks, you are likely in neoplastic liver. Minsan, ang problema kasi minsan, because this is a benign condition, it can be easily mistaken for a benign lesion kung biopsy lang ang pagbabasihan mo o kung microscope lang ang pagbabasihan mo for diagnosis. Okay? Minsan, clinical features, more often than not, this is an incidental finding lang. Pero pag medyo malaki, there may be hemorrhage due to rupture already. Next, which of the following characteristics favor a cholesterol stone? Is it greasy, brown in color, forms in a background of infection, or radiolucent? The answer here is it is radiolucent. So, with cholesterol stones, natandaan mo, this is usually at least 51% made up of cholesterol. So, kailangan majority ng component niya cholesterol. And, nagiging radiolucent siya usually kapag pure na cholesterol, made up of cholesterol siya. Pero pag may halo siya na calcium carbonate, it might be radiolucent as well. Next, we have a 45-year-old male presenting to the ER with severe abdominal pain related to the back. He has nausea, vomiting, fever, BP is 160/90, heart rate of 110, RR of 22, temperature of 38.5, PE shows tenderness and guarding of the upper abdomen. Blood test shows elevated levels of amylase and lipase as well as high triglycerides and liver enzymes. Ultrasound confirms the presence of gallstones in the gallbladder and bile ducts, which initiating mechanism would likely cause the patient's disease. So they're asking pathophysiology. So the first question is, ano ba meron ng pasyente ninyo? From the PE, abdominal pain leading to the back, and actually ang clincher dito, the serologic test of increased amylase and lipase would lead you to think that this is pancreatitis, acute pancreatitis specifically. So, likely yun naman ang nangyayari. So, the question now is, what is causing acute pancreatitis? So, remember na one of the more common etiologies for that is duct obstruction, secondary to gallstones. So, you call that your gallstone pancreatitis. So, the answer in here is duct obstruction. Now, acute pancreatitis, this is a reversible, note ha, reversible pancreatic parenchymal injury associated with inflammation. You have a lot of etiologies, pero ang common would be alcoholism and duct obstruction dito. You have hereditary types and some medications are involved, pero ito ang mas kailangan yung tandaan dito. Okay? And in Robbins, there's a nice figure there showing you the different na pathogenesis mechanisms ng acute pancreatitis. Pero I think ang pinaka-importante dito would be duct obstruction due to the for that case, that would be due to duct obstruction. Okay. So next, we will go into renal pathology. Okay, next, so we'll be discussing renal path. So by history, almost always merong tanong on renal path sa board exams. Tapos merong siguro always isang question or at least a series of questions kung case siya regarding one of the nephrotic syndromes. Kaya ang problema, hindi naman kasi natin usually nakikita itong mga syndromes na to. Aside of course from diabetic related complications. So, swerte nyo kung may nakita kayo. Tapos ang problema pa doon sa mga nephrotic, yung mga microscopic features dito, divided into light microscopy, immunofluorescence, and electron microscopy. Is totoo lang, konti lang nakakakita ng electron microscopy. So, kahit kami mismo mga pathologists, hindi namin masyado gamay. So, nagre-rely likely kung meron mang lalabas dito, it's going to be verbatim Robbins, yung mga descriptions. So, again, be careful about those questions. So, question 50, a 20-year-old male smoker presents to the ER with complaints of cough, shortness of breath, and hemoptysis. He also feels fatigued for the past week and has noticed a decrease in urine output. PE shows that he is pale and tachypnic, lung auscultation reveals bilateral crackles, and decreased breath sounds in the lower lobes. Lab tests show elevated creatinine levels and presence of anti-GBM antibodies. Chest X-ray reveals diffuse alveolar infiltrates. What is the likely diagnosis of this patient? Is it focus segmental glomerulosclerosis, systemic lupus erythematosus, granulomatosis with angiitis, or good pasture syndrome? The answer here is letter D. So to break it down, you have a 20-year-old male smoker with lung and kidney damage. Ang good differential dito would actually be letter C. So actually, kung medyo familiar kayo dun sa clinical presentation ng pasyente, you can already rule out these two. Okay? A and B. Una sa lahat yung FSGS kasi ang problema dito, this is more of a histologic diagnosis. Hindi ito yung pinag-ugatan ng problem. Ito lang yung manifestation sa kidney. Kaya itong dalawa, tanggalin nyo na to. So matitira ka dito with granulomatosis with angiitis and good pasture syndrome. However, ang magiging clincher dito is the anti-GBM antibodies. So, to review, ang pinaka-demographic natin for good pasture syndrome, 20s male active smoker with lung and kidney damage. Okay? Yun ang profile usually ng pasyente na may good pastures. Next, 12-year-old boy referred to the pediatrician for evaluation of persistent hematuria and proteinuria. He has a family history of kidney failure and hearing loss in the paternal grandfather and uncle. P shows high blood pressure, mild edema, heart murmur. Hearing test shows moderate sensory neural hearing loss. Examination reveals less dislocation and corneal dystrophy. Kidney biopsy shows basket weaving appearance of the glomerular basement membrane, so may splitting and lamination of the lamina densa. What is the likely diagnosis of the patient's condition? Is it Alport syndrome, Berger disease, Henoch-Schönlein purpura, or thin basement membrane nephropathy? The answer here is letter A, Alport syndrome. So you will notice na meron kang genetic component dito. So yun ang isang important clue natin dyan. So, because Alport syndrome is mostly X-linked, pero merong some forms that may have autosomal dominant or recessive na mode of inheritance sa kanila. Clinical features, you will be renal, so you would have hematuria, you will have nerve deafness sa ear, and then sa eye, you will have your lens dislocation, posterior cataracts, and corneal dystrophy. So, ito ang problema, kailangan ng electron microscopy findings. Okay? Again, in renal path, medyo important pa rin dito yung electron microscopy. While all of the other organ systems have already veered away from using EM sa diagnosis, the only, parang ang remaining na lang na very important ang EM is actually in renal path. Kaya, this is usually in the realm of the subspecialists already. Next, the presence of Benz-Jones proteins and amyloid in urine is indicative of which condition? Diabetic nephropathy, ATN, pyelonephritis, or multiple myeloma? The answer here is letter D, multiple myeloma. So, in the kidneys, ang presentation ng, you know that myeloma, di ba, siya, parang, these are tumors na mostly composed of parang neoplastic plasma cells. So, ang problema with those plasma cells, they secrete a lot of protein. Okay? At usually, those are monoclonal proteins. So, in the kidneys, it would manifest as having proteinuria. You will have light chain cast nephropathy. So, you may have your mga casts causing obstruction and inflammation. Amyloidosis, specifically the AL type. And you may have light chain deposition disease. Next, which of the following features is seen in autosomal dominant polycystic kidney disease? Mutation in PKHD1 can present with splenomegaly. Kidneys are large and subcapsular cysts are also enlarged. Common cause of deaths in infants is via renal failure. The answer here is letter C. The kidneys are large and subcapsular cysts are also enlarged. So, remember that PKD has two types, yung autosomal dominant and autosomal recessive. While their by virtue ng pangalan nila, mapapansin nyo na ang main difference nila is in the mode of transmission. But also, they're different kung ano yung mutations na present and kung ano ang morphology nila. In autosomal dominant, you have really large kidneys with varied size cysts na can get really large. Kaya ang main presentation nila is a renal mass with hematuria and eventually some form of CKD. Whereas in autosomal recessive, the mutation is PKHD1, and actually it's not in this table, pero yung kanilang morphology ng kidney nila, while the kidneys is still enlarged, it's not as nodular compared to the autosomal dominant, pero the cysts are actually finer and elongated compared to the really large cysts seen in your autosomal dominant. So next, we'll go into geopath. So next, we have a 25-year-old female presenting with dysuria, frequency suprapubic pain for 2 days. She is sexually active and uses condoms inconsistently. She has no fever, flank pain, or vaginal discharge. Urine dipstick shows nitrates and leukocyte esterase. Which of the following organisms would be most likely the cause of this patient's condition? So again, this is another one of those questions na nagtatanong ng etiology, ng microbiologic etiology. So you need to know your patient's parang profile para to pick the best answer in here. So, ang meron tayo, mukhang may UTI ang pasyente natin, pero there is a suspicion na meron siya STI because of this part of the clinical history that the patient is practicing unsafe sexual practices. So, ang question dito is ano yung babagi for this patient? So, actually, the answer here is Proteus vulgaris. And you may ask, Doc, parang walang sagot kasi nga dapat siguro STI dapat na related yung sagot. Unfortunately, pag sa mga ganitong pagkakataon, the only advice I can give you is choose always the best answer. So kung wala yung information na to, siguro dahil wala yung tamang sagot dito, then just choose an etiology that would be the most common na lang nalalabas. Kung ano yung common sa UTI. So, ano ba yung common na etiologies for acute and chronic cystitis, which is the official medical term for UTI. So, the most common would be your coliforms, so that would be your E. coli, Proteus, Klebsiella, and Enterobacters. You may have other bacteria seen, and fungi, parasites, and viruses, and even drugs can cause cystitis. Pero dun sa case natin, mukhang run-of-the-mill UTI lang siya dahil wala namang mukhang dun sa choices, there's nothing dun that would point to a sexually transmitted disease. Next, a 55-year-old male presenting with painless hematuria for 6 months. He also had recurrent UTI and dysuria, denied any history of smoking. So urine cytology showed numerous eosinophils and squamous cells. Urine culture was negative for bacteria. Cystoscopy revealed a large ulcerated mass in the posterior wall of the bladder. What is the most likely diagnosis of the patient's condition? Chronic cystitis, malakoplakia, polypoid cystitis, or squamous cell carcinoma. So first clue, painless hematuria. Pag ganyan, think of a mass already. Now, ang next clue, eosinophils and squamous cells. Okay? So, eosinophils, remember that eosinophils are usually seen in the background of parasitic infection. Plus, you have a combination of that and a large ulcerated mass in the posterior wall of the bladder. So, actually, dito pa lang, tanggalin mo na itong dalawang to. You are left now with polypoid cystitis, squamous cell carcinoma. Pero between the two, polypoid cystitis is benign. Squamous cell carcinoma is, of course, malignant. And you have ulcerated mass, so likely malignant na ito. Okay? So the answer here is squamous cell carcinoma. And the eosinophils dito is likely due to a previous schistosoma hematobium infection. So, let's review schistosoma. So you have your a lot of species in here, pero ang very important sa atin dito sa Pilipinas is Haponicum and Mekongii. Pero ang important dito na may clinical consequence talaga is hematobium because it usually has bladder involvement and that may lead to, that is a very important risk factor for the development of squamous cell carcinoma. So, ang importante sa bladder, you're gonna have granulomatocystitis, causing a calcified bladder, and note na na first schistosoma hematobium in cancer, note that it's squamous cell carcinoma. Hindi yung usual CA of the urinary bladder, which is transitional cell or urothelial cell carcinoma. Next, which of the following would be the cause of condyloma acuminata? Is it HPV-6, HPV-16, HSV-1, HSV-2? So, medyo mapanin lang dahil pare-pareho silang 3-letter acronyms tsaka may H and V. So, be very, huwag kayong clumsy dito sa mga ganitong klaseng questions kasi, panlin lang tong dalawang lang to. So, actually, you can remove this already. So between 6 and 16, you know that 6 is a lower risk HPV, 16 is high risk HPV. So between the two, since this is benign, choose HPV-6. Okay. So you know na because this is a benign condition, that's not progress to CA, it is likely being the patient is likely infected with low risk HPV. So mostly 6 rather than 11. Kung nandun yung parehong choices na to, choose HPV-6. Okay? So, they will appear to have papillary siya appearing on gross. Medyo, dark grayish ang appearance. It can be dark grayish to white ang appearance. Depende sa, sa exposures niya. Pero main morphology niya, it's going to be papillary, covered with squamous epithelium, and there's going to be coilocytic changes. Remember na pag meron kang HPV infection, your main histopathologic finding is going to be coilocytic changes. Kahit sa ang parte ng katawan yan, mapunta ka sa cervix, sa head and neck, ang HPV will always have a coilocytic appearance. Next, how long is the golden period in the management of testicular torsion? 1 hour, 3 hours, 4 hours, or 6 hours? So, sa mga ganitong tanong, it may, kung hindi nyo to alam dahil sa nabasa ninyo sa patho, baka alam nyo dahil sa alam nyo in urology instead. Kung may na-encounter kayong patients na may testicular torsion sa ER, yan, dito lalabas yung alam niyo na sa clinicals. So the answer here is 6 hours. So kailangan ma-manage yung patient within 6 hours or else there's no saving that testis already. So let's review testicular torsion. In neonatal patients, it's usually in utero or perinatal. No, it's not associated with any other anomalies. For adults, it's usually you have your adolescents with a bell clapper deformity. Usually, ang cause nito ay may tumor ka. Much like the ovarian torsion in females, it's going to be usually due to a tumor naman. So this is a true urologic emergency and you need to treat the patient within 6 hours when there's no saving the testis anymore. Next, 25-year-old male presenting with jaundice, abdominal pain, weight loss, no history of cryptorchidism, trauma or trauma or infection. PE shows a palpable right testicular mass, hepatomegaly. Serum beta HCG level was elevated at 1.2 million IU per liter. Ultrasound revealed a heterogeneous right testicular tumor and multiple liver lesions, which of the following microscopic findings is expected if a biopsy was done. It contains immature fetal tissue elements, has abundant clear cytoplasm with well-defined borders, uniform nuclei, and prominent nucleoli, markedly atypical cells with a solid glandular and papillary architecture, or has a biphasic proliferation of cyto and syncytial trophoblast. So actually, ang clue mo dito is number 1, may tumor ka. Pangalawa, beta HCG. So this is actually already telling because you have a male with elevated beta HCG hindi naman dapat umakit ang beta HCG sa lalaki. So there's going to be only one cause of this and that's choriocarcinoma. So alin dito magmamatch dan? That would be letter D, yung biphasic proliferation of cyto and syncytial trophoblasts. And yes, it can happen, choriocarcinoma in males, that can really happen despite having no innate production of trophoblasts. So, Choreo CA is commonly is a component of mixed germ tumor. So ano yan, likely ang nakita lang doon is sa microscopy is just one component, pero remember that the pure forms of this is extremely rare. The gross, there is small primary tumors with hemorrhage and necrosis, and microscopy should show cyto and syncytial trophoblasts. Clinical features: markedly increased beta HCG. Yan ang pinaka-importanting finding dito. And they can have a lot of distant metastasis dito. We've seen patients na merong met sa brain with choriocarcinoma. Next, which of the following terms refer to a state when the sperm motility is less than that of the reference value? Is that astenozoospermia, teratozoospermia, necrozoospermia, or azoospermia? Now, I find this question unfair. Kasi hindi lahat ng schools naman nagtuturo ng semi-analysis. Or kung meron man, it's just parang one-off na session in the lab. And this is not even in Robbins. Our reference here ni Dr. Elomina is WHO and another specialty textbook, which is Henry's yung for clinical pathology. So pag nagulat kami na tinanong to kasi parang how are we going to teach to this hindi naman nakaka-encounter ng semi-analysis during their normal med school. So yeah, unfortunately the answer here is asthenospermia, and you have no choice but to go over this. Hindi ko alam kung lilitaw to ulit kung one-off lang to sa board exam. So let's just go a little bit on sperm analysis. So why do you conduct this test? It's for fertility testing. Remember, when you're doing fertility testing, hindi lang ang problema ang babae. The males we can also have the problem. So you need to investigate both parties always. Okay? Investigate both parties. Unfair kung babae lang ang tinetest ninyo, kung hindi naman siya may kasalanan. So for post-vasectomy assessment, so this is very important because when males have do vasectomy, then expectation wala ka dapat sperm, di ba? Or kung meron ka man lang parang prostatic fluid, that's it. Pero you're not supposed to have sperm para hindi na makakause ng pregnancy ng lalaki. In forensic analysis, this can be used to detect the presence of semen, and I would like to refer you now to your notes in legal medicine. So, ano ba yung tinitingnan? So, as with any other fluid, you always examine macroscopy, so yung gross appearance ng fluid mo, and then microscopy. So, this one, so a lot of these are actually hanggang dito. These are macroscopic findings, and this one are all the microscopic findings na ginagawa nyo. Some microbiological and chemical tests are done, pero they are not routine. Special muna siyang i-request. Ang usual kasi na ginagawa for microscopy is motility, vitality count, and morphology. At kung mayroon bang other cellular elements present other than spermatozoa. So, these are the terms na ginagamit. The problem in here is that these terms are not used anymore in the sense na the WHO has recommended na veering away from these terminologies already. So just for reference na lang ito, pero kasi ang problema nila basta sa previous exam eh. So, ito yun, yung astenozoospermia, you have sperm motility less than the reference value. The other term I believe is teratozoospermia. You have other forms of the spermatozoa. So, yung normal is less than the reference value. Necrozoospermia, konti lang ang viable sperm. Azoospermia, walang spermatozoa at all. Okay, next we deal with gynepatho. So again itong section na to, baka hindi lumabas sa patho na board exams, pero baka lumabas naman sa OB-GYN na exam ninyo. Number 62, diethylstilbestrol exposure is associated with which of the following conditions? Leukoplakia, extramammary paget disease, septic vagina, papillary hydranoma. So the answer here is letter C, septic vagina. So actually, kasi like in any other issue sa na pag-aaral ninyo in environmental na diseases. Ang issue kasi dito is dapat familiar kayo dun sa mga exposures ng mga pasyente na are teratogenic. Eh, ang problema, minsan hindi naman tayo familiar sa mga chemicals na ito. So, yun dun magiging medyo mahirap lang. Kung hindi kayo familiar sa chemical na that can cause what disease, then you might have a problem in answering these kinds of questions. So with diethylstilbestrol or DES, so this is associated with septic vagina and vaginal adenosis. Next, clue cells in the pap smear indicates the presence of which lesion? Candida, actinomycosis, Gardnerella vaginalis, or Trichomonas vaginalis. So actually, all of these choices are can be found in the pap smear. So actually, required kami na as patho na sabihin kung ano ang organism na present sa smears kung meron kami makita. So clue cells dito, very important finding yan for Gardnerella vaginalis, also known as bacterial vaginosis. Okay, so yun yung the etiology is Gardnerella. Clinically, your patients would have vaginal discharge with fishy odor and is likely due to an imbalance of normal flora. So, kung hindi man clue cells ang gamitin na term, ang pwede kasi is a very basophilic grainy background. Yung nakikita lang namin as for the diagnosis of bacterial vaginosis via pap smear. So again, these are gram variable Coccobacilli seen, no long bacilli organisms. Very important na makita namin ito. Okay? So the clue cells, ano ang pwedeng description na gamitin? Those are squamous cells that are covered with organisms. Yung mismong squamous cell, punong-puno siya ng mga Coccobacilli all over. So the diagnosis, clinically, there is a thin white yellow homogeneous discharge, presence of clue cells. Vaginal fluid pH is more than 4.5, is more than 4.5, and then positive for the whiff test. I think ito ginagawa to rather ng OB rather than sa ito lang yung sa amin sa pathoside. Okay, 64, a 32-year-old female visited her gynecologist for her annual pap smear. A few days later, she received a call from her doctor informing her that her pap smear showed low-grade squamous intraepithelial lesion or LCIL. Which of the following is true regarding this lesion? A, she needs to have a TABI so done ASAP. B, she should be informed that there's a high chance that this will progress likely to carcinoma. C, there's a high possibility that this lesion will regress. D, she should be informed that there's a high chance that this will progress to HCIL. The answer here is letter C. There's a high possibility that this lesion will regress. So actually for LCIL, dapat fina-follow up ng ang patients, hindi parang i-obserbahan mo lang siya. So let's review CIN. So this is actually the old term, yung CIN, cervical intraepithelial neoplasia. Although you may see some of the senior OBs still use this term, so na lang kayo, worry dun sa exam ninyo. Okay. Etiology of this is HPV infection. So you may see some low risk HPV and high risk HPV. Very important, of course, yung mga high risk HPV nyo are the ones that are likely going to progress to squamous cell carcinoma. Important site sa cervix natin would be the transformation zone kasi doon likely magkakaroon ka ng progression to CA. But that doesn't mean that there can be no progression to CA mula sa ectocervix at just sa endocervix alone. Okay? That can still happen. So the morphology is the nuclear atypia. So actually dati kasi ginagamit pa yung SIN, so it's divided into 3. SIN 1, SIN 2, and SIN 3. However, ang naging issue with the 3-tiered classification system is that sometimes the doctors don't know what to do pag napunta siya sa gitna. Parang anong gagawin natin? Kasi parang middle ground siya. So it's better, or parang the idea now is just to classify it into either low grade, which is SIN 1, and then high grade, which is SIN 2 or 3. So, LCIL is not treated as a pre-malignant lesion and will often regress. And HCIL has a high progression to carcinoma. So, let's look at the following tables. So, again, right now, ang terminology, dapat SIL na ang ginagamit, standing for squamous intraepithelial lesion. Scene 1 is L-seal, while Scene 2 and Scene 3 is now considered as H-seal. Now, if you look at the table over here, it will show you that L-seal has a high has a high percentage of regressing. Kaya observation lang ang ginagawa dito. Or usually a follow-up pap smear or kung medyo alanganin yung pathologist dito sa diagnosis, di may proceed with biopsy, with a punch biopsy para makita lang kung meron bang kung L-seal lang ba siya or meron na bang feature suggestive na H-seal na siya. Kasi pag H-seal na siya, then you are running the risk of progression towards CA. So you might need to be more aggressive in the management of your patients para hindi na siya mag-progress to CA. Next, which of the following statements correctly describes endometriosis? Is it A, endometrial tissue seen within a leiomyoma, B, endometrial tissue seen within the myometrium, C, ectopic endometrial tissues outside the uterus, D, endometrial glands with atypia? The answer here is letter C. Endometriosis refers to ectopic endometrial tissues outside the uterus. So let's go over the definitions. Okay? When you say adenomyosis, it is when you have endometrial tissue in the deep myometrium. Usually, ang nakikita in more advanced textbooks, it's going to be at least one low power field away from the endometrium. Okay? Now, let's go back to the choices. Itong endometrial tissue seen within the leiomyoma, this actually describes your adenomyoma. Okay? So again, adenomyosis kung nasa myometrium lang, adenomyoma kung nasa yung glands and stroma mo na endometrium are seen within the leiomyoma. Kung nasa labas siya ng uterus, you call that your endometriosis. All of them are actually related and would have the same pathogenesis. Okay? So now, some cancers though may arise from endometriosis because of the presence of these three important mutations. Between these three, mapipiliin ako, KRAS ang pinaka-importante dyan. The last one dito sa choices natin, this is already refers to at least endometrial hyperplasia with atypia or carcinoma na. Okay. Morphology, these nodules, these yung mga endometriotic glands and stroma would appear as red, blue to yellow brown nodules within the dun sa surface ng tissue mo. Size, very common size would be the ovary or the laparotomy scars. We've seen appendices and even sa surface ng colon na nagkakaroon ng endometriosis. Okay? And very important na consequence ng endometriosis is adhesion. So minsan magre-resect ng colon dahil daw may adhesion, so merong GI symptoms ng patient mo, pero yung pala endometriosis lang siya. Okay? So findings na very important would be infertility, severe dysmenorrhea and dyspareunia, and menstrual irregularities. In adenomyosis and to a certain extent adenomyoma, meron kang menometrorrhagia, dysmenorrhea, dyspareunia, and premenstrual pelvic pain. Next, which of the following microscopic findings favor a finding of uterine carcinosarcoma? A, there should be a malignant epithelial and mesenchymal elements. B, malignant smooth muscle cells with necrotic areas. C, mildly atypical glandular cells in a papillary architecture. Or D, markedly atypical cells arranged in a glandular architecture. Now, microscopic findings, remember, verbatim Robbins yan. So, actually dito, may clue ka na. Carcinosarcoma means that you have two elements. Okay? The malignant epithelial, yung carcinoma component, and the sarcoma component. So, dapat may mesenchymal element ka. So, the answer here is letter A. Do note na the carcinosarcoma term has only been used for the uterus quite recently, a few years ago lang. So, your examiner might use the term malignant mixed Mullerian tumor or MMMT. Kaya, be vigilant lang na they might use the old term na dun sa exam ninyo. Again, the old term of carcinosarcoma is MMMT pero wala yung pinagkaiba sa carcinosarc. personally speaking, I'd rather use the term carcinosarcoma kasi from the name itself, it's already very descriptive na meron kang carcinoma component and sarcoma component, hence ito. Now, the carcinoma component can be quite varied, and even the sarcoma to section areas can be quite varied as well. So the carcinoma component can be any uterine carcinoma. So endometrioid adenoCA, serous carcinoma, clear cell carcinoma, pwede. And then for the sarcoma component, you may have endometrial stromal sarcoma, which is actually what we usually see. Then, or pwede ding leiomyosarc, or even the presence of some heterologous components. Ibig sabihin, may kahalong muscle, cartilage, adipose tissue, or bone. And prognosis of these is generally poorer compared to your well-differentiated endometrial CA. Next, 55-year-old woman presented with postmenopausal bleeding, no other complaints or significant history, merong massa right adnexa, transvaginal ultrasound reveals solid ovarian tumor measuring 8 cm in diameter, resected ovary reveals the presence of urothelial cells arranged in nests. What is the likely diagnosis of this tumor? Is it serous carcinoma, Krukenberg, Brenner, or teratoma? The answer here is Brenner kasi ang serous carcinoma, this is of Mullerian origin. So this is what you usually see. Ito yung mga high-grade serous carcinomas. Krukenberg tumor is another term for colonic CA na nagmetastasize sa ovary. Teratoma, of course, these are your germ cell tumors. Ito yung yung either mature cystic teratoma, ito yung mga mabubuhok, maraming buto, o kaya immature teratoma, which is parang siyang may blastemal cells ka. Brenner is when you have your urothelial cells. So again, Brenner tumor, urothelial cell nests in the ovary, usually unilateral, and these are actually benign. Now, itong question na to, medyo, you will see, consistently present siya sa mga exams, and it's usually, some variation of this question. Which of the listed features favor a partial hydatidiform mole? So actually ito, at saka yung IBD, yung parang almost every year lumilitaw at least one version of the comparison between the two major classifications. So ito for partial, so they're asking alin dito ang partial mole. A, uterine size that is smaller than expected for age of gestation. B, absence of the embryo or fetus. C, marked trophoblastic proliferation. Or D, beta HCG level of more than 100,000 milli-IU per ml. The answer here is letter A, the uterine size that is smaller than expected for age of gestation. So, again, I refer to you with this very important table in your handouts comparing the difference between your partial mole and complete mole. So, for partial mole, very important, triploid, 16 with 69 chromosomes. Tapos nun, smaller for date na uterine size. HCG levels, mataas pero hindi siya more than 100, pero less than 100,000 milli-IU per ml. Then, present ang embryo and fetus. Yun usually na tinatanong. So, for the complete mole, diploid siya. The diagnosis is from a molar gestation. Tapos large for date na uterine size and very very high HCG levels. This is actually an underestimation. We usually see mga complete moles na over 1 million ang kanilang beta HCG. And the rates of subsequent gestational trophoblastic neoplasia are very high in a complete mole compared to a partial mole. Very important as na findings, no fetus. Very rarely do they ask the microscopic findings kasi parang pang specialty na ito. Pero ang quick rundown lang nito is partial mole. From the name itself, there's only partial proliferation of your trophoblast. So kung meron kang villi, nandun, lang siya, patchy lang yung proliferation niya. Whereas for a complete mole, kailangan complete circumferential na proliferation sa mga villi. So that's it. Let's proceed now to breast patho. So, in breast patho, unfortunately, hindi siya masyadong tinatanong sa mga exams, sa patho exams. Kung tatanong man ng breast, siguro sa surgery. Pero it's unfortunate nga na, na ang taas-taas ng incidence ng breast CA, pero hindi siya masyadong tinatanong sa exams ninyo. Pero kung magtanong man, at least ito yung mga usual topics na lumalabas. So, a 45-year-old female presented with a palpable lump in her left breast na napansin niya 2 months ago. She had a history of breast reduction surgery 5 years ago. She denied any trauma, pain, nipple discharge, or family history of breast CA. On physical examination, the lump was firm, mobile, non-tender, measuring about 3 cm in diameter. Overlying skin was normal, nipple not retracted, no axillary lymph nodes palpable. What is the likely cause of the patient's complaint? Now, remember na sa mga clinical presentations ng breast CA, kapag meron kang palpable lump, kaya may bukol na nakakapa, your differential should not be limited to neoplastic. Okay? Because there are some non-neoplastic lesions that may appear as lumps pa rin. So, kasama doon actually is fat necrosis and granulomatous mastitis. Mag-appear yan as lump. And based dito, you can actually rule out already acute mastitis kasi non-tender. Tanggalin nyo na yan. Ang acute mastitis usually dapat may pain yan eh. Pain and non-tender. Fat necrosis usually, may history ka dapat ng trauma, which this patient has. Paget disease of the breast, dapat nasa nipple ito, and mukhang normal naman yung nipple, so you can cross this out. Invasive breast CA is always consideration kapag meron kang mass. So, actually between the two. However, what you notice here is meron siyang history of a surgery 5 years ago. So baka yun inciting incident for this condition. So this is likely fat necrosis. So mag-ingat kayo dyan na hindi lahat ng breast masses dapat ang isipin nyo agad is neoplastic. So either fibroad or CA agad. Hindi wag ganon sa breast. Tingnan niyo yung history ng pasyente niyo. So, fat necrosis, a very important na patient profile would be history of breast trauma or surgery, and this is due to an action of blood and tissue lipase of breast fat. Morphology, you may see some fat necrosis like what you see sa sa pancreas kapag nagkaroon ng pancreatitis. Now, 50-year-old female seen in the clinic due to an enlarged left breast. Mastectomy revealed a well-circumscribed mass with stromal proliferation with leaf-like stromal projections. What is a likely diagnosis of this lesion? Carcinoma medullary pattern, metaplastic carcinoma, fibroad, or phyllodes tumor. So number one, you can actually remove remove all your differentials based on what's written in here. 50-year-old female, so na siya, beyond na siya sa usual age for having a fibroadenoma, and fibroadenomas are generally small. You have an enlarged left breast at mukhang the mass is occupying the entire breast. Now, it says na well-circumscribed mass. So actually, you can already remove A and B from there pa lang. Kasi these two would have invasive patterns. So, matitira, phyllodes tumor, which matches the description of having leaf-like stromal projections. So, letter D ang tamang sagot. So, phyllodes, important sa phyllodes, usually seen around 40 to 50-year-old females. At so, ang usual presentation ng patient na to is they have very, very large breasts. Sobrang asymmetrical ng breast nila na tipong ang laki ng difference ng right sa left because one breast is so enlarged because of this tumor. This tumor can occupy the entire breast. Okay? So, huwag kayong magugulat doon. Now, and the problem with phyllodes, it can range from benign to malignant. And of course, pag malignant, you're going to have the features of malignancy, infiltrative borders, atypia, mitosis, and you may even see some malignant heterologous elements. For example, osteosarcoma ng breast, that is likely secondary to a phyllodes tumor. Pero makikita nyo pa rin yung stromal overgrowth. Now, you also have yung borderline, which has at least one but not all criteria, and then you have the benign na dapat zero features of malignancy over there. So next, we deal with endopatho. In endopath naman, ang feedback is, well, number one, consistently meron diabetes question. So that helps. Pero yung mga other topics, medyo, hindi ganun ka-frequent na merong parang yung mga endo na sakit. Maliban lang talaga sa diabetes. Siguro second doon would be yung mga thyroid issues kasi yun yung common na na-encounter natin sa clinics. Pero other than that, it can be present, it can be wala. Yung lalo na yung mga syndromes, they do ask minsan. So, again, be vigilant lang on those topics. So, question, 45-year-old female presents with a 6-month history of excessive thirst and urination, drinks about 8 liters of water per day, urinates about 10 times per day, with a total urine volume of 7 liters. She complains of headaches, fatigue, and visual disturbances, no history of DM, hypertension, or renal disease. PE shows a BMI of 22 kilograms per meter square, normal BP and HR, no signs of dehydration. Neuro-PE reviews bitemporal hemianopsia. Lab test shows low serum sodium and urine osmolality, high serum osmolality, and low plasma vasopressin level. What is the likely diagnosis? So actually, this is a bit much na there's too many things to consider in here. Pero I think one very important PE outside of the endocrine findings is the bitemporal hemianopsia, which you usually see only kapag meron kang pituitary lesion or something na may mass ka sa suprasellular component ng brain mo. Kaya ang magiging tanong dito is, alin kaya dito ang likely secondary to a pituitary mass? So that's going to be your letter B, central diabetes insipidus. Okay? So, continuing from the previous case, what is the likely cause of the patient's condition? As we have discussed earlier, likely a suprasellular mass. Kasi kasasabi ko lang, the helpful clue there is the bitemporal hemianopsia. So let's go over the posterior pituitary syndromes. Kasi usually, what you may see sa clinics is the anterior, or kaya naka-admit sa ward, yung anterior pituitary. Minsan lang ang posterior pituitary kasi kung na symptomatic na endocrine related. Kung meron man, these are the syndromes na aalahanin ninyo. So you have your central diabetes insipidus, nephrogenic diabetes insipidus, and SIADH. Okay. Now, for very important is the laboratory tests that you will do for this patient to distinguish the three findings. So again, for central DI, that will be normal to high serum osmolality, low urine osmolality, and low serum ADH. So for pituitary diseases in general, it's classified mostly into two, kung hyperpituitarianism yung patient mo, which means there's a hormone excess, or hypo, which is a hormone deficiency. Pero madalas kasi, ang nakikita natin, parang endocrine-wise, wala kang makikita sa pasyente ninyo, pero they do have the, and you call those your non-functioning adenomas. So usually what you see are the symptoms related sa mass effect. So that's your visual field defects and increased intracranial pressure. Very rarely do we see the pituitary apoplexy na complication. Pero do note kung ano ibig sabihin nito. That just means may hemorrhage ka. Now, for nomenclature naman, you may see a difference between sa WHO and Robbins. Because in WHO, they have renamed the term as yung pituitary adenoma as PITNET. While pituitary carcinoma is metastatic PITNET. Kasi if you're going to go sa old criteria, the only way to diagnose pituitary carcinoma is kung mayroong presence ng metastasis. Kasi there is such a thing called as normal endocrine atypia. So atypia is not, so for endocrine tumors in general, hindi lang atypia ang pagbabasihan mo kung siya ay malignant or hindi. Okay, there are other criteria na importante. Pero for between pituitary adenoma and carcinoma, ang very important na criteria would be this one, metastatic PITNET. I have only seen one case of this, and that was very, very difficult to diagnose kasi we really need to go back sa history. We needed to go back sa history ng patient just to find out that the patient has a previous pituitary adenoma, and we have to do certain stains that are not even discussed here para lang masabi na of pituitary origin yung kanyang tumor. That's how difficult the diagnosis of pituitary carcinoma is. Okay? So, morphology, it can be divided into kung greater than or equal to 1 cm or less than 1 cm. It may have a pseudocapsule but can be locally invasive. But remember, even if it's locally invasive, your criteria for malignancy is still metastasis. Okay? Clinical features, you may see hyperpituitarianism or mass effects. Usually, mass effect lang to. Kasi madalas na nakikita namin non-functioning adenomas. Next, 40-year-old male presenting with a 2-month history of ocular focusing deficits, proptosis, periorbital edema, and diplopia. Has been symptoms of hyperthyroidism, weight loss, palpitation, tremors, and heat intolerance. Thyroid function tests show low TSH, high free T4 and T3 levels. TSH receptor autoantibody was positive. What is the likely diagnosis of the patient's condition? So, may autoantibody, tanggalin nyo na agad lahat ng non-autoimmune dito na differential. So that would be colloid goiter and granulomatous thyroiditis. So you're left with C or D. And kung hyperthyroidism, then this is likely going to be Graves' disease. So the answer here is Graves' disease. So Graves' ophthalmopathy yung nakita natin sa case na yon. It's usually seen in around 25 to 30% of cases. And kung may ophthalmopathy, you will see exophthalmos. So yung naka-protrude na yung parehong eyes ng pasyente due to to increase glycosaminoglycan synthesis sa muscles ninyo. Kaya nagpo-protrude siya forward. Now, ang features nito would be definitely exophthalmos and impaired extraocular muscle function. So they won't be able to move their eyes freely to sa directions. Now, ang main etiology ng Graves' ophthalmopathy is of course Graves' disease. So you need to remember na because this is an autoimmune disease, you are likely you can measure the autoantibodies in your patient. And yes, this is available sa mga laboratories natin. Itong thyroid-stimulating immunoglobulin. So, morphology ng thyroid in a patient with Graves' disease, they are symmetrically enlarged, soft, meaty cut surface. On microscopy, diffuse hypertrophy and hyperplasia. You're going to see a lot of that parang scalloping sa mga colloid nodules, which will indicate that this is marami kang active na colloid dun sa sa thyroid mo. Iyan yung scalloping na yan, yung moth-eaten na architecture sa colloid. It means in general na active yung thyroid mo. Okay. You may see some inflammation kung meron man, some interstitial lymphocytes as well. Pero kung meron mong germinal centers, konti lang yan. Mas marami yung naka-intersperse between the different na follicles mo. Next, which of the following thyroid diseases is associated with a viral infection? Hashimoto, lymphocytic goiter, or granulomatous thyroiditis. So you can actually remove Hashimoto here as well kasi Hashimoto is usually autoimmune. So ang tanong na lang is between lymphocytic goiter and granulomatous thyroiditis, pero with viral infection that is actually associated with granulomatous thyroiditis. So let's review that. This is the most common cause of thyroid pain. So usually, pag meron kang thyroid mass, ang presentation ng pasyente mo, painless yan. Okay? So kung merong pain, actually, nagna-narrow down yung differentials mo. So this is a very good differential, granulomatous thyroiditis. Secondary to a viral infection nito. Usually, may urti ang pasyente mo followed by a thyroid enlargement. Pero mawawala din naman yan after the resolution of the infection. Now, which of these neoplasms is associated with amyloid deposition? Medullary, papillary, anaplastic, or follicular? Very important sa exams. At least siguro every now and then they do ask something related sa amyloid. Pero remember that amyloid can affect any part of the body and it has different diseases depende kung saan siyang parte. So for thyroid, magiging association ng amyloid mo would have to be medullary carcinoma. So sa brain, iba din yan. That's called Alzheimer's, ganyan. And you can have amyloid deposition as well sa liver, depende na lang kung ano yung disease na meron sa pasyente ninyo. Okay. So, medullary CA, very important is the origin. And the origin is the parafollicular C cells, and it's associated heavily with your multiple endocrine neoplasia syndromes, specifically MEN2. Okay? So, it has a varied architecture, pero yung very important is the amyloid deposition, and you're going to see that the cells are arranged usually parang medyo, yung mga atypical cells mo are arranged usually in nodules. They are polygonal with granular amphiphilic cytoplasm and then inconspicuous nucleoli. Note that these are very aggressive and you may see lymph node metastasis upon diagnosis. Among the IHCs, pinaka-important dito would be calcitonin. And in fact, you can, one of the things that you can do is to do pre-op serologic calcitonin on your patient, tapos makikita mo na sobrang elevated. Then, you consider medullary CA. Next, 53-year-old man with hypertension for 10 years, presented with edema, fatigue, and foamy urine. BP was 180/100, by BMI is 28 kilograms per meter square. HbA1c is 9.5. Urinalysis showed proteinuria na sobrang taas ng levels. Hematuria sobrang taas din. Creatinine is 3.2, super taas. eGFR is napakababa. So, a QT biopsy was performed. Which of the following microscopic findings is likely compatible given the patient's condition? Is it uniform diffuse appearance of the capillary wall, tract appearance of the GBM, presence of crescents, or presence of Kimmel-Style-Wilson lesion? So, ang pinaka-important na clue dito is your patient is diabetic. 9.5 na HbA1c for a long. Ibig sabihin, minimum of 3 months, merong siyang gantong kataas sa A1c level, so his diabetes is likely uncontrolled. Likely, it's going to be letter D, the Kimmel-Style-Wilson lesions seen in nodular glomerulosclerosis. So, let's review diabetic nephropathy. So, the main finding is your nodular glomerulosclerosis, and you're going to have diffuse capillary basement membrane wall thickening. Next, 35-year-old female presents with episodes of severe headache, sweating, and palpitations for the past 6 months. Also has hypertension and DM. She has a family history of MEN2 syndrome na mention natin yung kanina when we're talking about medullary CA. Blood test showed elevated levels of catecholamines and metanephrines. CT scan revealed a 3 cm mass in the right adrenal gland. Which of the following microscopic findings would you expect if the mass was resected? A. Zellballen arrangement, so chief cells surrounded by sustentacular cells. B. Should resemble normal adrenocortical cells. C. Spironolactone bodies are present. Or D. They are well differentiated to bizarre giant cells with moderate to marked atypia. So, ano ba meron yung pasyente? MEN2 syndrome, headache, swelling, palpitation, elevated catecholamines and metanephrines, may MASCA, think pheochromocytoma. So, alin dito ang compatible with pheo? That's going to be letter A, Zellballen arrangement of chief cells surrounded by sustentacular cells. So, these are pheochromocytoma. This is a medullary chromaffin cell tumor producing catecholamines. So, you can measure those catecholamines for a serologic diagnosis of your patient. And Zellballen arrangement ng chief cells are very, parang pinaka-buzzword for pheo under microscopic. However, it's not limited to pheo. You can also see the Zellballen arrangement in paraganglioma. Okay? Metastasis, like in pituitary carcinoma, the only reliable criterion of that is the only reliable criteria for malignancy in pheo, isang malignant pheo, is metastasis. So, kailangan present siya. Parang yung pituitary carcinoma natin kanina. Important na features, hypertension and headache, palpitation, diaphoresis. Please remember the rules of tens of this, for pheochromocytoma. It's still true up to now. So, review lang ng MEN2A syndrome, also the Sippel syndrome. The main anomaly is the ret gain of function mutation. And you can have a lot of tumors arising from MEN2A. Very prominent though is the parathyroid hyperplasia, medullary thyroid carcinoma as we mentioned earlier, and of course your pheochromocytoma like we see in this case. So next we go now into dermapath. Okay, so for derm path, konti lang by history yung lumalabas dito based from the previous feedback. Pero kung meron man, hindi din siya yung mga lesions na common. So let's go over some topics na nakita namin lumabas sa previous exams. So, number 78, which of these skin lesions are present in Gorlin syndrome, SCCA, basal cell CA, actinic keratosis, or adenosquamous carcinoma? And the answer here is basal cell carcinoma. So, basal cell CA is actually the most common human malignancy, okay? Despite na parating nakikita sa mga epidemiology na topics on cancer, na lung is the highest o kaya breast ang highest, na it's more on mortality kasi. Basal cell carcinoma kasi is a very well-behaved malignancy. As long as ang treatment kasi nito excision lang tapos pag na-excise at wala kang natira, it's as good as treated na yung pasyente ninyo. In fact, the metastatic potential is so low sa mga pasyente na may basal cell CA. In some countries, they even allow blood donations in patients with basal cell CA. So actually, here in the Philippines kasi, ang rule is kapag may basal cell CA or any cancer in general, bawal mag-donate. Pero in some countries, kapag nalaman nila na basal cell CA lang, minsan pinapayagan nila. So that's how low yung metastatic potential ng cancer na to. Ina-allow nila mag-donate. So, Gorlin syndrome is here. That's an autosomal dominant condition na usually patients have with multiple basal cell carcinomas in less than 20 years old, 20 years of age. Pero note na meron kang extras clinical features na outside of the skin. So you can have medulloblastoma, ovarian fibroma, or odontogenic keratosis. Okay? So, ang importance sa kanyang microscopy, nest of basaloid cells invading the dermis, you have your peripheral palisading, and your stromal reaction. Next, a 55-year-old woman presents with a 3-month history of painful blisters and sores in her mouth that make it difficult to eat and drink. She also has some blisters in her chest and back that rupture easily and leave raw areas. PE shows multiple erosions and crusted lesions on her oral mucosa, as well as flaccid blisters on her trunk. A skin biopsy from the blister shows na she shows acantholysis and suprabasilar blisters. Labs show elevated levels of antibodies against desmoglein in the blood. What is the likely diagnosis of the patient's condition? So actually, this is kind of uncommon question. Minsan nagtatanong sila ng blistering diseases sa skin and we don't know why the examiners have this fixation on blistering diseases kung medyo rare ito in actual practice. So ito yung mga choices natin: pemphigus vulgaris, bullous pemphigoid, dermatitis herpetiformis, or epidermolysis bullosa. The answer here is letter A. This is pemphigus vulgaris. Mahirap to if you're not very familiar with the blistering diseases of the skin. So I suggest na balikan niyo yung part lang na yon just in case na magtanong sila on this topic. So, pemphigus vulgaris is actually the most common type of pemphigus, and the main pathogenesis is there are immunoglobulins against the desmoglein. So, important dito, morphology, suprabasilar blisters, and acantholysis. When you see acantholysis, so meron kang mga rib pegs tapos nagsiseparate dun sa area na yon. So, kaya nagkakaroon siya ng blistering kasi nagsiseparate yung part ng skin na yon from the dermis. Okay. So, actually, this table is not in the handout, but it's a good table to see the comparison between the different na blistering disorders sa skin, kung ano yung pathogenesis nila, Okay? Remember that if we're dealing with antibodies, it's more likely a possibility that these antibodies are available for testing serologically. So ito, likely meron pero I'm not sure if which hospital has it kasi medyo rare ang ang ma-diagnose for these kinds of conditions. So siguro kung meron man sila-send out to sa ibang bansa. Please do note that there are some with associations with extra dermal lesions such as with pemphigus vulgaris, may association with non-Hodgkin lymphoma, and dermatitis herpetiformis associated with celiac disease. Next, bones, joints, and soft tissue. Again, this topic is quite rare as well. Kung may lalabas man siguro isang question lang na, or isang case, I think. So, we have a 10-year-old boy referred to a pediatric orthopedic clinic due to recurrent fractures. Patient has a history of multiple fractures beginning with a broken femur at birth and has had several additional fractures over the years, including a broken wrist and a fractured tibia. PE reveals that he is short for his age and has a blue tint to the whites of their eyes. Their patient also has mild scoliosis, which is not causing any discomfort at the present. What is the likely diagnosis of this patient? Osteogenesis imperfecta type 1, osteogenesis imperfecta type 2, osteopetrosis or mucopolysaccharidosis. Actually, dito pa lang, the fact na meron siyang blue tint doon sa white ng eyes, medyo telling ito kasi there's only like one condition na sobrang dinidrill sa utak natin during med school that is associated with this finding, yung pagkakaroon ka ng blue sclerae. So that is actually osteogenesis imperfecta. So ang tanong na lang is it type 1 or type 2? Ang history ng type 2 is usually this happens in utero. Yung fractures happens in utero and your baby is not usually compatible by birth kasi the mere strength of the contractions ng mother during pregnancy is enough to kill yung baby. Kaya this one is actually type 1. Ang pinaka-clue nyo dyan, nag-survive siya till, in childhood so far. So, osteogenesis imperfecta, please take note na there are autosomal dominant and recessive types. Ang recessive is usually type 2. While the other, yung 1, 4, and 3 are dominant, ang pinaka nakikita natin is usually type 1. Okay. So, ang main pathogenesis niya, there's a deficiency in type 1 collagen synthesis, producing too little bone, resulting in increased fragility leading to fractures. Ang important na features, the translucent blue sclerae, hearing loss, and dental problems. Types 1 and 4 are compatible with survival as we can see with this patient over here. And number 2 is the most severe type. Next, a 65-year-old female presented to her primary care physician due to back pain and height loss of approximately 2 inches. Meron siyang smoking history and sedentary lifestyle. Further investigation revealed bone density scan which revealed a T-score of less than 2.5 SD. Which of the following forms of physical activity should the physician recommend in order to prevent the progression of the patient's disease? Is it Zumba, biking, weight training, exercise, or walking and jogging? Now, this may seem parang, sapato ba talaga to? Pero actually kasi there is a reason kung bakit to tinatanong dito. Now, so ano bang diagnosis muna ng pasyente na to? It looks like na this your patient has osteoporosis, especially given the bone density scan result. So, what prevents the progression dito? Kailangan mag-weight training exercise ng pasyente nyo because that is preventive. Magre-respond kasi yung mga osteocytes sa cells mo dun sa mechanical stress and that would help push the bone to be stronger by intaking more calcium. So, weight training exercise ang tamang sagot dito. Okay. So, let's review. For osteopenia, osteoporosis, basically ang osteopenia, decreased bone mass lang, dapat ang score mo is -1, in between -1 and -2.5, while osteoporosis is less than 2.5 standard deviations ang kanyang bone density score. Etiopathogenesis, usually aging, pero it's also associated with estrogen deficiency. So, yung pag naka-menopause na yung pasyente, usually nakikita natin yung mga osteoporotic patients na ito. So, ang clinical features depends on the affected bones. There might be loss of height, like what we see in this patient. There might be pulmonary embolism as well, and pneumonia kung merong immobilization na due to fracture of the femoral neck. Pero how to prevent? Do the weight training exercise. Next, which of the following tumors is associated with McCune-Albright syndrome? Fibrous dysplasia, osteoclastoma, chondroma, or osteosarcoma? Now, this one, unfortunately, you have not, dahil nga nagtatanong ng syndromes, no choice pero rote memorization ito. The answer here is fibrous dysplasia. So fibrous dysplasia has monoostotic or polyostotic types, and even under the polyostotic types, you can have syndromes depende kung ano ang extra osseous manifestations niya. So in Mazza-Brown syndrome, you can have your polyostotic fibrous dysplasia plus your myxomas, while your McCune-Albright syndrome would be usually polyostotic fibrous dysplasia plus your endocrinopathies. And what ang yun ang hahanapin nyo in kapag ang pasyente mo may fibrous dysplasia. So I think ang important dito is yung isa sa mga buzzwords for fibrous dysplasia is the curvilinear trabeculae of woven bone. The other one is yung parang Chinese characters in description, pero sa totoo lang di naman siya mukhang Chinese characters. Very important though is no osteoblastic rimming. Kasi pag meron kang osteoblastic rimming, kung positive to, it denotes that you are in normal bone. Next, an 32-year-old female experiencing foot and hand pain for a few years visited her healthcare provider after hand pain, neck stiffness, and fatigue worsening over the last 3 months. Lab test shows high levels of rheumatoid factor and anticyclic citrullinated peptide antibodies. If a joint tissue biopsy was done, which of the following findings would you expect? Acute inflammation, pallus formation, tophi formation, or osteoclast-like giants? So the first question, ano ba muna yung diagnosis nito? I think very telling dito is the hand pain and the anti-citrullinated peptide antibodies or ACPA. So the diagnosis in here is actually rheumatoid arthritis. Okay, this is rheumatoid arthritis. So which of the following findings would you expect from rheumatoid arthritis? That is your pannus formation, which is actually the pathognomonic finding for this disease. So, this is one of the most common inflammatory arthritis usually seen among the elderly, mga 4th to 5th decades. Please know, main morphology, pannus formation. Okay? So, ang problema kasi sa pannus formation, there is joint fusion already because of this granulation tissue and fibrosis dun sa between the joints. So, kaya siya pain initially on pain siya after being prolonged na walang ginagawa, relieved via movement kasi when you move, you break the pannus sa mga pasyenteng ito, kaya nare-relieve sila when you move the joints na. The most common joints affected are usually the small joints rather than the big joints. So you have to compare this to osteoarthritis na kung saan baliktad naman. So in osteoarthritis, ang issue mo naman doon, nagkikis-kisan yung bones. You call that your bone hibernation. Tapos noon, in osteoarthritis as well, ang naapektuhan are the larger joints first rather than the small joints. So, siguro ang marker na, if you're going to do laboratory tests on this patient, you can do definitely your ACPA. Some laboratories already have this, pero mas common pa rin na nakikita namin in the labs is the rheumatoid factor. Okay, next, MSK patho. Now, by history, almost always may lumalabas dito kahit naman in real life. Hindi ka nakakakita ng mga gantong klaseng kaso. Siguro once lang siguro or twice in your clerkship or internship. Pero sa boards, consistent na meron silang tanong regarding some of the lesions in here. So let's go through some of yung mga usual na lumabas. So, number 84, which of the following clinical presentations are consistent with the diagnosis of Guillain-Barré syndrome? 60-year-old female with numbness, loss of pain sensation, and paresthesia. B, 37-year-old male with painful vesicular skin eruptions along a sensory dermatome distribution on his abdomen. 40-year-old female with a raised red patch along the face with loss of sensation. 50 or letter D, 56-year-old male with numbing and tingling in both feet and progressive difficulty in ambulation with loss of deep tendon reflexes. The answer here is letter D. Yung 56-year-old male, numbing and tingling in both feet, progressing to difficulty in ambulation. So ano ba yung mga atong mga other clinical scenarios na to? Yung A, this sounds like DM nephropathy, although it would have helped kung meron kang history ng DM sa pasyente na to. Letter B is shingles because of the distribution sa abdominal skin eruptions mo. And letter C is actually leprosy. So Guillain-Barré, this is a type of demyelinating polyradicular neuropathy, and important dito is the risk factors niya coming from infections of Campylobacter jejuni, CMV, EBV, and Mycoplasma. This is a T-cell mediated reaction. Meron kang cross-reactive antibodies to peripheral nerve components. And then for musculoskeletal lesions in general, usually kung may demyelination ka, 'di ba? Ano ang mangyayari? Magkakaroon ka ng atrophy sa mga muscles mo, kaya magkakaroon ka ng weakness. Kaya after the acute flu-like illness, meron kang ascending paralysis. Ito actually yung pinaka parang clue mo dito, the ascending paralysis. With or without loss of sensation. Should you do lab tests, you can find albuminocytologic dissociation. So which means there's an increase in CSF protein without significant increase in the inflammatory cells. Next, you have a 52-year-old man complained of difficulty swallowing, cough, shortness of breath for 3 months. Meron din siyang muscle weakness and tenderness in the proximal limbs, as well as meron siyang heliotrope rash and Guthrun's papules. Pulmonary function test showed restrictive lung disease, tested positive for anti-Jo1 antibody. Lung biopsy showed interstitial fibrosis and inflammation. What's the likely diagnosis? Is it dermatomyositis, polymyositis, Charcot-Marie tooth disease, or inclusion body myositis? The answer here is letter A, dermatomyositis. So actually, this is one of the cases na medyo notorious. Itong diagnosis na to, itong lesion na to, medyo notorious sa tipong nagkaroon ng parang 3 questions regarding this item in the patho exam. So I don't know what the fixation of the examiners to this topic is. So ano yung dermatomyositis? It's the most common inflammatory myopathy in children. However, in adults, this is usually due to a paraneoplastic syndrome. So pag adult, tapos yun ang presentation, maghanap kayo ng tumors. Morphology hallmark would be perifascicular atrophy. Features would be myalgia, weakness, and important dito are the cutaneous manifestations. So that's your heliotrope rash and Guthrun papules. Actually, dun sa case kanina, medyo alam mo na yung nakita mo na yung buzzword na to, heliotrope rash and Guthrun papules, solve ka na eh. Alam mo na yung sagot sa case na yon. Kung meron mang remember this is autoimmune, so kailangan meron kang antibody again, and then this one ang meron kasi is the anti-Jo1. So next would be CNS patho. Okay, next CNS patho. Now this one is actually a high yield na organ system na aralin for the board exams. We find na there's always a few questions, around 5 na regarding the CNS of varying topics. So, from basic pathology all up to neoplasia, nagtatanong sila always on CNS for the past few exams. So, number 86, which of the following cells react to injury by demyelination? Is it neurons, astrocyte, microglia, and oligodendrocytes? So, this is one of those questions na topics sa sinabi ko before in liver na mayroong specialized reaction yung organ system. So you need to be familiar with this one along with dun sa liver on how do cells react to injury. So this one, oligodendrocytes ang tamang sagot. So when we go and review now the different reactions of the cells to injury, yung neurons, which is the most number of cells sa CNS natin, they react by causing the red neuron. Pero pag naging chronic ang yung condition, there will be neuronal loss. For astrocytes, they would react via gliosis, so dumadami at lumalaki yung mga astrocytes natin, or nagkakaroon ka ng geniostocytes. Pero more often than not, it's gliosis. Okay? And as sabi nga nito, it's the most important pathologic marker of CNS injury. Microglia, ang nangyayari is nagkakaroon siya ng microglial nodules mostly. And oligodendrocytes undergo demyelination. Next, which of the following findings listed below is part of Chiari-2 malformation? Hypoplasia of the dermis, low-lying cerebellar tonsils through the magnum, downward extension of the cerebellar tonsils and the medulla to the magnum, or brainstem nuclear dysplasia. The answer here is letter C. Okay. Letter A, I believe, is Dandy-Walker malformation, while letter B is Chiari-1. So Chiari-2, are also known as Arnold-Chiari malformation, as mentioned nga, downward extension of the cerebellar tonsils and medulla through the foramen magnum. Next, tuberculous meningitis is expected to have which CSF profile? Increased glucose, increased protein, increased glucose, decreased protein, decreased glucose, increased protein, or parehong decrease ng glucose and protein mo. The answer here is decreased glucose, increased protein. So much like any na bacterial na infection sa brain, you would note because bacteria consumes sugar, so you expect nyo na yung glucose mababa sa CSF while yung protein levels tumataas. Okay, so TB, of course, kailangan very familiar kayo dapat sa TB because we're in the Philippines. There's always usually a question regarding TB naman anyway sa exams ninyo. So, in the brain do, ang morphology niya, it can appear as either meningitis, so meron kang distribution sa mga basal sisters and around cranial nerves. Usually, nasa base ng brain mo makikita yan because that's the location na meron kang high oxygen tension. Or, instead of meningitis, it would appear as a mass known as your tuberculomas. So, for tuberculomas, ang manifestation mo mostly, it would be a mass effect sa brain. Kasi nga, it's space-occupying lesion. And remember that because rigid yung skull natin, there is not much volume that the brain can take kung hindi magkakaroon ka ng herniation. Microscopic findings, of course, yung usual findings mo, the caseating granulomas. And then, you may also see obliterative endarteritis and adhesive arachnoiditis. Next, which of these findings is immediately expected after direct parenchymal injury of the brain? Is it hemosiderin-laden macrophages, gliosis, plaque John, or vasogenic edema? So, immediately expected. So, expect an acute finding over here. And there's only one answer. That's letter D, vasogenic edema. All the other three are usually seen as chronic findings already. So, for direct parenchymal injury, either due to contusion or lacerations, for pathogenesis niya, because of the trauma, you will have disruption of your vascular channels, causing hemorrhage, tissue injury, and edema. So, edema yung unang-unang magiging reaction to injury dito, followed by the hemorrhage and eventually inflammation. Old finding mo would be plaque John, and you will see the gliosis and hemosiderin-laden macrophages later on. Next, where is the most common location of a saccular berry aneurysm? Now, this one, yung mga gantong klaseng questions can either be here or sa anatomy exam ninyo. So, please be worried that they may do ask clinical questions in your anatomy exam. So, just correlate. So, is it A, between the middle and anterior cerebral arteries? B, junction of anterior cerebral and anterior communicating arteries? C, junction of middle cerebral and posterior communicating arteries? Or D, junction between the posterior cerebral or and basilar arteries? The answer here is letter B, junction ng anterior cerebral and anterior communicating artery. So while we discussed aneurysms kanina, yun yung first question natin kanina, I think. So first, saccular aneurysms, this is the most common type of an intracranial aneurysm and most common cause of a spontaneous subarachnoid hemorrhage. Please note of its associations. Most common site would be at the circle of Willis in the ACA-ACOA junction. Yun yung anterior cerebral and anterior communicating artery junction. Clinical features would involve sudden severe headache followed by syncope. So, and saan yun? Ito, anterior cerebral artery mo. Itong side ito yung communicating artery. It's in that junction between the two vessels. Ito. Next, 68-year-old male, increased difficulty in initiation of voluntary movement and increasing inability to perform activities of daily living for the past 2 years. PE shows tremors at rest and expressionless phases. What is a likely diagnosis of the patient? So, elderly, meron kang parang inability to perform activities of daily living, tremors. So, this is Parkinson disease. So this is one of your neurodegenerative diseases already. So, Parkinson disease, ano ba muna yung Parkinsonism? Kasi yun yung symptoms na na-exhibit ng patient natin eh. That's your masked phases, yung diminished facial expression, slow involuntary movement, and tremors. Okay. So, Parkinson disease, this is loss of ang cause ito is loss of the dopaminergic regions in neurons in the substantia nigra. And very important for all neurodegenerative diseases, there is some sort of proteinopathy in your patient. So, meron kang mga inclusions most of the time. And this one, it's your Lewy body, which contains your alpha-synuclein. Noted, Lewy body is the histopathologic finding. Yung protein, yung proteinopathy mo, it's your alpha-synuclein. Yun yung, nakikita natin within the Lewy body. Next, 65-year-old male presented with progressive headache, confusion, and left hemiparesis for 2 months. MRI of the brain showed a large enhancing mass in the right frontal lobe with surrounding edema and mass effect. He underwent craniotomy and gross total resection of the tumor. Histopath revealed a slightly cellular pleomorphic astrocytic tumor with pseudopalisading necrosis, glomerular blood vessels, and mitotic activity. Molecular profiling revealed no mutation for IDH1 and IDH2. What is the likely diagnosis of the brain tumor? Glioblastoma IDH wild type, glioblastoma IDH mutant, astrocytoma grade 4, IDH wild type, astrocytoma grade 4, IDH mutant. So actually, itong topic na to, it is not anymore in Robbins. This is actually an update na nilagay actually ni Dr. Ilomina para sa inyo just in case the examiners want to be updated sa mga kasi we've been using this new nomenclature I think last year pa or last year actually to be more specific. So you know na this is going to be because astrocytic siya with necrosis, mitotic activity. This is likely glioblastoma or some severe form of an astrocytoma. So, ang tanong na lang is based on the current nomenclature, is it IDH wild type or mutant? So, ang question is, ito yung clue kasi natin no mutation for IDH1 or IDH2. The question now is, what does it mean to be IDH mutant or IDH wild type? When you say IDH wild type, ibig sabihin, hindi siya related sa mutation na yon. So, IDH wild type, no mutation for IDH1 and IDH2 yon. While IDH mutant means na meron kang mutation present in IDH1 and IDH2. So, tanongin nyo, what's the purpose of this ba? Because clinically speaking, for patients with IDH mutant, ibig sabihin may mutation for IDH1 or IDH2, usually have a better prognosis compared to those na IDH wild type. Okay. So now actually, they revised the nomenclature. When you say something is glioblastoma, it is automatically IDH wild type. So mali na tong letter B na to. And if you have this kind of morphology sa tumor mo, and yet meron siyang mutation, you will say na it is only an astrocytoma grade 4 IDH mutant kahit na pangit yung microscopic features sa brain. So actually, itong letter B at letter C na to, this does not exist sa current nomenclature natin. So it's between A and D, and because there is no mutation for IDH1 and IDH2, this is IDH wild type. The answer is letter A. So, glioblastoma, IDH wild type, it's the most common primary malignant tumor in adults. So, ang problema, this is a very, very aggressive already. Very poor ang prognosis sa mga pasyente na ito already. Okay? So, microscopically speaking, it will be the same as an astrocytoma, WHO grade 4 na IDH mutant, pero ang difference nga lang nila is the presence of the mutation. Ito, no, it's not related to IDH1 or IDH2 mutations. Okay? So, ito yung, I just copy-pasted yung note ni Dr. Elomina sa handout ninyo. Glioblastoma, by definition, should be IDH wild type, mainly because they have a poorer prognosis compared to a similar looking lesion, pero IDH mutant. So, let's review IDH mutant astrocytoma. By the name itself, kailangan present ang mutation, either IDH1 or IDH2. Grade 4, very cellular, very atypical, increased mitosis, pero very important to differentiate it from grade 3, the presence of necrosis or microvascular proliferation. Okay? So, yan yung necrosis would be pseudopalisading, and this one, you have multi-layered endothelial cells within the vessels, and they can form your glomeruloid structures. Next, 55-year-old woman presented with a progressive lower back pain and weakness in both legs for 6 months. No history of trauma or infection. CT scan of the spine showed a well-circumscribed round mass at the T12 level with broad-based dural attachment and calcification. Mass was compressing the spinal cord and displacing it anteriorly. No evidence of bone erosion or invasion. Underwent laminectomy and a stereotactic biopsy of the mass. Which of the following findings would you expect from this tumor? So, ang pinaka-important na finding dito is the fact that it's a well-circumscribed round mass. So, think na this is something na more benign behaving. And it's at a location, dural, sa T12. So, actually, iisa lang ang iisipin nyo dyan, and that is a meningioma in this case. So, alin dito ang microscopic findings that would represent, that will be consistent with the meningioma, and that is letter B, syncytialness of monomorphic bland epithelioid cells. So, meningioma, the most common type is meningothelial, usually extra-axial dural-based mass with a dural. So, this can be actually one of your spinal cord masses, okay? So, no, most common type is meningothelial type, pero you can have the Samamoto's type. There are also an atypical meningioma and yung atypical meningioma and the malignant version of the meningioma, pero hindi na yun kasi kino-cover sa Robbins. May mga may mga clinical, may mga features, microscopic features that would make it a higher grade na meningioma. Pero that's beyond the scope of this this lecture na. Next, which of these CNS tumors is likely to be associated with ataxia? Now, this one is actually kind of a difficult question because it would necessitate you to understand paano nagkakaroon ng ataxia ang pasyente. Anong lesion sa brain ang magkakos ng ataxia. So actually, when you're talking about ataxias, these are usually of cerebellar in origin. So ang next question ngayon is, alin dito ang cerebellar na lesion mo? Is it medulloblastoma, meningioma, primary CNS lymphoma, or glioblastoma IDH wild type? The answer here is medulloblastoma. Okay? So, yeah, letter A ang tamang sagot dito. So, medulloblastoma, second most common primary malignant tumor in children, associated with Gorlin syndrome. Usually, na-mention natin si Gorlin syndrome kanina, di ba? In basal cell carcinoma, so tandaan nyo yung connection nyo with medulloblastoma as well. Important is the location. So actually, ang always sinasabi ng mga neuropathologists is, if you have pediatric patient na cerebellar, ang una mong iisipin dapat is medulloblastoma. Kasi these are very aggressive, pero very radiosensitive. So maganda ang okay ang treatment sa mga patients na to. Finding is like in any tumor ending with a blastoma, small round blue cells. Tandaan niyo na, basta blastoma ang suffix ng tumor mo, expect nyo na ang cells mo ay small round blue cells. May pseudorosettes, may rosettes ba? Yes, so Homer right pseudorosettes are present. Usually itong mga blastomas na to kasi may nagkakaroon ng rosetting formation eh. So, last would be I. Medyo uncommon na may I question. Either 1 or 0 yan usually sa exam. So, question, the 3-year-old girl was brought to the ophthalmologist by her parents noticing a white glow in her left eye while taking photos. Doctor examined her eye with an ophthalmoscope and saw a white mass behind the pupil. Also noticed that her left eye is slightly larger than the right one. Which statement is true regarding the patient's condition? So, ano ba muna yung condition ng patient na to? Leukocoria in a pediatric patient, think retinoblastoma. So, anong dito ang totoo regarding regarding retinoblastoma? Is it A, both copies of the RB gene had the gain of function mutation? B, this tumor should likely have a metastatic focus in the liver as well? C, the RB gene mutation leads to unopposed CDK activation promoting cell cycle progression? Or D, this disease is due to GNAC and GNA11 mutations? The answer here is letter C. The RB gene mutation leads to unopposed CDK activation promoting cell cycle progression. So actually, kailangan nalabihin nyo retinoblastoma kasi I think this is one of the yung parang prototype na mga ng mga genes involved in malignancies back in the neoplasia chapter. So continuing from the previous case, which of the following microscopic findings would you expect? Is it Flexner-Winter sinus rosette, Homer right pseudorosette, epithelial cells with round nuclei and cherry red nuclei, D, nests of basaloid cells with peripheral palisading and stromal retraction? This is letter A, your Flexner-Winter sinus rosette. This is actually the common buzzword na nilalabas nila for optha questions in the patho board exam. So, let's review retinoblastoma. This is the most common primary intraocular malignancy in infants and young children. Etiology is RB loss in chromosome 13. So, it can be heritable. So, meron ka ng germline mutation, which is the first hit, and then a second mutation second somatic mutation. Or kung sporadic ito na condition, dito naman na then you should have 2 somatic mutations before you can have retinoblastoma. So, ito yung main pathogenesis natin regarding the RB loss. And like in any blastoma, as I mentioned, small round blue cells. Kung mayroong special feature, yes, present. Flexner-Winter sinus rosette ang tawag doon. And main clinical feature, leukocoria. So that's it actually for your review in organ system pathology. Good luck in your exam. The topics that I have discussed here in Pearls may or may not appear in your exam because remember, they can ask any topic in pathology under the sun in this exam, which makes it really difficult. So that would require you really to be familiar in all of the diseases in Robins, and that is actually very difficult. So I would suggest really being familiar with the common ones, tsaka yung mga main pathophysiologic mechanisms outlined in the early chapters of Robins para alam nyo na kung paano siya balik-baliktarin pagdating sa exam ninyo. And with that, good luck in your exam, and I hope to see you on the other side. Thank you.